Well, good morning, everyone. My name is Brianna Romines, and I'm honored to serve as president for the Epilepsy Foundation of Michigan. And it's my pleasure to welcome all of you to day 2 of the Upper Midwest Rare Epilepsies Conference, presented by the Epilepsy Foundations of Greater Chicago, Michigan, Minnesota, and Wisconsin. As many of us know, there are 3.4 million people diagnosed with epilepsy in the United States, and 1 in 26 people will develop epilepsy in their lifetime, with an increasing number of people being diagnosed with a rare form of epilepsy. Though advances in research and genetics are resulting in an increased understanding of many of these syndromes, there is still much to learn. These rare forms of epilepsy can greatly alter a person's life, and the more we understand them, the better equipped we are to address the challenges that they can present. Now, yesterday's presentations focused largely on research and therapies, and today we'll shift toward exploring the impact of rare epilepsies on day-to-day living and quality of life. And we'll discuss some of the key considerations in planning for the future. We'll also have some time to address a variety of other topics in our Rare Epilepsies Open Forum. Before I introduce our first session, I want to thank the Rare Epilepsy Network for helping us plan and promote this conference. The Rare Epilepsy Network, or REN, works with urgency to collaboratively improve outcomes of rare epilepsy patients and families by fostering patient-focused research and advocacy. REN includes over 70 rare epilepsy organizations and broad epilepsy stakeholders, including the Epilepsy Foundation, committed to this common mission. So definitely take some time to visit their website and learn more. Now, I'm very pleased to introduce our panel of speakers for the session entitled Supporting Physical, Mental, and Cognitive Health in Epilepsy Care. Dr. Jana Jones is a neuropsychologist from the University of Wisconsin-Madison. Dr. Sucheta Joshi is a pediatric epileptologist from Michigan Medicine C.S. Mott Children's Hospital. And Dr. Isa Dawoodi is the president and co-founder of Ring 14 USA and a parent of a child with a rare epilepsy diagnosis. Together, they'll discuss the importance of integrating physical, emotional, and cognitive well-being into epilepsy care decisions. Before we get started, Russ Derry, the Director of Education at the Epilepsy Foundation of Michigan, will go over some housekeeping tips for using this Zoom webinar platform. Russ?
Thank you, Brianna, and welcome everyone. Today we'll be using Zoom webinar, which looks a little different from a regular Zoom meeting. As an attendee using a computer or smart device, you'll only be able to listen and view the presentations. We can't hear or see you. At the bottom of your screen, you'll have the option to chat or use the Q&A feature. Please use the chat feature for any comments you'd like to make or resources you'd like to share that relate to the topic being discussed. And make sure that your chat is set to all attendees and panelists so everyone can see your comments. If you think of any questions during the sessions, please use the Q&A feature and we'll do our best to answer as many questions as possible at the end of each presentation. As an attendee calling in from a telephone, you'll only be able to listen to the presentations. Okay, so let's get started with our first session, Supporting Physical, Mental, and Cognitive Health in Epilepsy Care. Okay, let's make sure all of our panelists unmute themselves and show their smiling faces. Okay, Dr. Jones.
It says my video has been stopped.
Oh dear. Can someone, I believe someone—
It says the host has stopped it.
Yeah, the host
okay.
should be able to ask you to share your video.
Okay.
There we
go.
Hello.
Right.
Look at that. We're all lined up nicely on the top too. Okay, so can we start by having each of you briefly share a bit about your background, your interests, and your experience with this topic? Dr. Dawoodi, do you want to get started?
Sure. So like Brianna said, I am the co-founder and the director of Ring 14 USA. So we advocate for a very rare syndrome called Ring 14 syndrome. And that is a structural variant. So it's a chromosomal issue So a little bit more complicated, the genetics than the normal, not the normal, but the rare monogenic syndromes. And then I'm also had the pleasure of being in the chair of REN, which was introduced also the Rare Epilepsy Network. But most importantly for this panel, I'm the mother of 3 daughters, and my youngest, Marie, just turned 16, and she is my daughter who was born with ring 14 syndrome. And so I'm going to kind of bring the perspective of how this affects the whole family and my other daughters and the husband, because epilepsy is one of these syndromes that really does affect the family unit. And this is really true with the severely impacted individuals. And also, I just want to mention that I have a sister who has partial complex seizures that sometimes generalize into tonic-clonic. And we just recently, my oldest daughter has started having these. So there's something else running in our family, but it gives me the perspective of the profound and the rare, but it also gives me the very different perspective of how epilepsy affects adults and the differences in how those two interactions work. So thank you. It's an honor to be here.
Thank you for joining us. Dr. Joshi.
Good morning. First of all, thank you to the Epilepsy Foundation, Russ and Brianna, for inviting me to be part of this panel. I am at the CS Mott Children's Hospital, which is part of Michigan Medicine in Ann Arbor. We were formerly called the University of Michigan Health System, but now are known as Michigan Medicine. And I am one of the group of pediatric epileptologists in the Division of Pediatric Neurology at Michigan Medicine. I take care of a lot of children with all forms of epilepsy. And being in a medical center and a children's hospital like Michigan Medicine, the rare epilepsies are really not so rare in my practice. And I really hear what everybody is saying today about the impact that these epilepsies and this group of disorders, if you will, have on a child, on the family, on their milieu and everything around them. So one of the things that I try to do in my practice is not just update prescriptions and pick medicines and read EEGs, which I do a lot of, but really try to think of the child and the family as a whole and treat them all. I like to think of myself as a team member for everybody, whatever is the name of the child. And I really like to take this as a team approach in treating their epilepsies. So with that perspective, I'm really delighted to be part of this panel to share and answer questions, but also to learn from everybody. So thank you again for inviting me.
Great, thank you. Dr. Jones.
Hi, thank you so much for inviting me to come today and to participate in this conference. It's a really unique opportunity, especially to have all of these states represented in the Midwest. I'm at the University of Wisconsin in Madison. I'm a neuropsychologist. I've been working in epilepsy for a number of years now. My primary interests are in comorbidities, so cognitive difficulties, problems with depression and anxiety. And I also started out in the field working with folks who had more complex problems and developmental disabilities, and working with families and trying to see how to integrate people into the community. So hopefully we will have some good suggestions and be able to have a good conversation about well-being.
Okay, great. So because difficulty achieving seizure control is common among those with rare epilepsies, it's understandable that seizure control is a primary objective of the epilepsy care team. But to individuals with rare epilepsies and their family members, the impact of epilepsy and its treatment on physical, mental, and cognitive health can be equally, if not more important. Can each of you talk about the importance of open and ongoing communication about goals and priorities between patients, caregivers, and the epilepsy care team? And let's just go in the same order that we went. Dr. Dooley, do you want to go first?
Man, I'm going to have to start off all of these questions. That's a lot.
Okay, I can mix it up.
I'm teasing. This is such an important topic because as your child goes through, being diagnosed and you're really in the heat of it, and then as your child grows, in the rare epilepsies, sometimes it's the comorbidities that really take over. And so this open communication between you and your caregiver is so important because sometimes it's the other issues that rise to the top, like GI issues or sleep issues or all of these different things that really impact your life. And more importantly, sometimes it's the open communication between you and your spouse. So it's no secret how high the divorce rate is among the families with special needs. And in particular, and I think some of that strife comes from the fact that parents have different ideas on how to care for their children and the stresses of that. And so I'm sure that there's many different strategies to kind of combat that. But one of the things me and my husband have found is that when we disagree, and we both are opinionated people, and we are both highly invested in her care because we treasure her so much, is that we kind of take when we disagree, we try to go with the most conservative path. And so just kind of knowing how to navigate that beforehand when we go into discussions of care, it has been really helpful in our relationship, in realizing also that our daughters are really impacted by her care. And so their opinion is important. They're not the person who makes the ultimate decision, but they want to be heard because her care impacts their life as well. And that was especially true when they were younger. And so this communication and just being really honest about what your goals are. And sometimes it's seizure control, sometimes it's crisis control. And sometimes there's fatigue in trying to try a new thing, you know what I mean? And the constant, and so we have to give grace for that as well.
Great. Dr. Joshi or Dr. Jones?
Here, I can go next. If we are sticking with the order. I think Dr. DeWoody highlights some very important points that should be central to the management of epilepsy for any child. And I cannot emphasize enough the importance of open and ongoing communication. As I just said when I introduced myself, it really is like a team sport. There is the child with epilepsy at the center, and there is everybody around the child talking to each other. We also have to remember to talk to the child while we are having that conversation, because while we all talk about seizure control, the next best medicine, the next best treatment, I think sometimes we have to take a step back and see where does that fit in the big picture. And the only way to do that is by open communication. I've always maintained that writing a prescription is the easiest thing I do in my practice. And if that's all that I did, I would see patients in and out in 10, 15 minutes, but it's really not about that. It's about taking everything else into account. Yes, we started a new medication, but the outcome of that has been, this child is falling asleep in the classroom or is not able to attend school. And, was that the goal of what we were doing, or are we trying to balance quality of life and education? So I think, and unless we talk and communicate openly, we are not going to achieve those goals. And things may look different for one family versus another. Just to give an example, when we talk about things like vagus nerve stimulation, if there is a child for whom being in the class, participating in, let's say, some sort of classroom activity where there's a lot of talking is going to be challenging, and the voice change associated with vagus nerve stimulation can be a barrier, that needs to be taken into consideration when you plan these treatments. In many of the rare epilepsies, the ketogenic diet is a fairly advocated treatment, which us epileptologists love for what it can do for a child's epilepsy, but sometimes it can have a massive impact, not just on the child, but on their family as well. And again, when we take this team approach and we communicate with families, it's very important to share all those things. And I guess what I'm saying is to listen. That really is the key when it comes to that open communication, so that you have goals and everybody sharing those and everybody knows what each other are talking about. The last thing I'll say is we see patients, we say our children in our clinic for half an hour, 45 minutes every so often, but their families are with them 24/7. So the perspective that they bring is, I think, is a very important factor in this open dialogue and communication. I could go on forever and ever, but I'll give Dr. Jones some time also.
Yeah, just to kind of build on that, I think one thing to remember is that each family's goals and priorities shift over time. And sometimes families can feel frustrated that they're not being heard or their needs aren't being met. And I think because the goals and priorities shift over time, it's good to have another discussion. And if the frustration can be an indicator that discussion should occur. And it's not necessarily that the medical providers are ignoring the needs of the patient and the family, but maybe they're not sort of up to speed on what the current priorities are for the family and the child. So I think remembering that too is to kind of maybe start off with that discussion, revisit what the priorities are, revisit what the struggles can be, and kind of get everybody on the same page again, because things may have changed in the last 3 or 6 months since you were into your appointment. And I think it's good to kind of refresh, see where we are now, see where we want to go, and sort of what the long-term and short-term goals are for the care currently.
Right. Well, great points. So one theme that often comes up in shared decision-making about epilepsy care is the concept of risk. Each partner in the epilepsy care team may have a different risk tolerance and may prioritize safety versus independence and quality of life differently. And that influences a wide range of decisions, including whether or not to wear a helmet, what activities to participate in, what living situations might be possible, how aggressive to be in the pursuit of seizure control. Can each of you share an example of a situation where risk was a factor that had to be carefully considered and negotiated in an epilepsy care decision? Dr. Joshi, do you want to go first? Ooh, look at that, mixing it up.
Okay. So absolutely, I think this is central to shared decision making. Absolutely. I'll share an example. This is not necessarily a rare epilepsy as identified by a genetic condition, but it is certainly something that I think impacts all of us in our decision making situations. So, as I just mentioned, we often use the ketogenic diet as a treatment modality for several epilepsies. And while this can be very effective in treating seizures in some situations, it is not something that is as easy or as, it just takes a lot of time and investment and discussion. And there have been situations where, on one hand, as a physician, I have felt like this is the treatment for this child. But then when I look at it from a family's perspective, like, why is this treatment not working? It really is a huge barrier for quality of life for what this child and family can participate in. And to the point that it actually became a negative situation for treating this child's epilepsy. And so while we were sort of in hot pursuit of seizure control, and I would say we did achieve good seizure control, the side effects, if you will, of the treatment that we prescribed, the those side effects completely outweighed the benefits of the treatment. So I think we had to all take a step back and say, you know, what are we doing over here? What are we treating? We had to think up a plan B for treating this child's epilepsy. And, you know, we were able to come up with a plan B that provided good seizure control, but at the same time, we were not blindsided by the fact that, you know, this is the treatment we know, this is the treatment we're going to go with. And I think in that situation, you know, we definitely had to, the risk that we were running into over here was extreme depression around the diet, extreme anxiety over situations, and that became a risk that had to be taken into account, that you know, the child and therefore the family's mental well-being was just as important as keeping this child's seizures under control. So again, I think it's very important that you take all these factors into account every step of the way when you're making treatment decisions.
Okay, great. Dr. DeWoody.
Sure. I love this idea of risk and what you're comfortable with and what the family is comfortable with. And I think that this is one of these things that changes over time. And so, you know, just from our perspective and what I've seen in our community, sometimes this tolerance for risk changes. And so when you're newly diagnosed and in the heat of the moment, your tolerance for risk kind of is low. You know, you stay at home, you isolate, you try to do everything you can to get these seizures under control. And then as you grow more comfortable with care, you realize that the whole family has to live. And you kind of, from our perspective, we had an increase in our tolerance for risk because we wanted quality of life, not only for Marie, but for ourselves. And so I'm asked all the time, do you travel? You know, and this is something that is very individual for each family and for, you know, they have to negotiate these terms. And, you know, my answer was always have diastat, will travel, because I realized for us that we had to assume a certain amount of risk in order to live our lives and to have quality of life amongst ourselves. And so that's one instance where you know, that's something that my family really enjoys to do, and we were not willing to kind of give that up. And furthermore, if we stayed home, she had seizures. If we traveled, she had seizures. And so that was just a risk that we kind of tolerated. But with regards to this mental health, and I'm just going to throw in my older daughter just for a second, is that as these patients get older, and my daughter is a young adult now, that I think we have to have a real respect for their tolerance of risk, because one of the things that that I've seen is that she needs her independence, and I can't let my fear interfere with her ability to live her own life. And at some point, it's not my tolerance for risk in that case that's really influential. It's her tolerance for risk, and I have to be respectful of that, because her control over her life very much affects how she deals with her condition, and it empowers her when I give her that ability to choose her own risk and to respect that. And so I really appreciate the physicians who I don't know, who are just very sensitive to that fact that families have different levels of risk, individuals have different levels of risk, and it is their life and their choice, and we have to honor that.
Great. Really, really important comments. Dr. Jones, any thoughts?
So that's a perfect segue to my story that I wanted to tell you. It basically centered around some discussions with a family and the daughter who had epilepsy and also an intellectual disability. And the discussions were primarily about independence and risk and failure. If the freedom went too far, what would happen? And so we had lots of discussion about this, and we had one of the discussions was to leave this particular patient at home alone after school before mom got home. And so we sort of talked back and forth about what to set up for safety precautions and how much time was the kid and the mom okay with the kid being home alone. And so they practiced some different activities and set it all up. And I got a phone call from mom a couple of weeks later, and she was kind of laughing. And she said that they tried it, and the daughter decided to pop popcorn before mom got home. And she burned the popcorn and she burned up the microwave. And I was like, oh no, are you all right? Is everything all right? And mom laughed and she said, you know, it's okay. It was great. All we have to do is buy a new microwave, but everything went well. And now she knows what the parameters are for popcorn. And we bought a better microwave where you just push the popcorn button. And she said, you know, and then I started reflecting that even at work, people burn popcorn all the time. You could smell it flowing through the office pre-COVID. And so it was good to just sort of put it in the context of something that did go wrong, but everything was okay. And for me as a provider, I have to tell you, I was a little nervous because I was like, oh no, here I've been encouraging independence and risk and taking some chances that are sort of educated chances, but we still burned up a microwave. But it's good to remember that, you know, we all take risks in every part of our lives, and sometimes it goes well and sometimes it doesn't go well. But you sometimes do have to take those risks in order to create independence. And but anyway, I just wanted to just share that story with you, that, you know, it's something we just have to work with and balance all of the time.
Yep, absolutely. Okay, so now let's dive into those three wellness domains that are mentioned in the title of this session: physical, mental, and cognitive health. Let's start by talking about physical health. As a group, rare epilepsies can affect pretty much every body system, including the nervous system. And most of these systems are also susceptible to treatment side effects. What are some of the most common challenges you face when it comes to the impact of epilepsy and its treatment on physical health? And how have you addressed some of those challenges? Dr. Jones, do you want to start this time?
Sure. I think some of the challenges are with physical health is, you know, kind of even talking about a simple thing like exercise. So how much exercise is good exercise and how much is going to put a child or adult at risk, and so, you know, just trying to find that balance. I don't prescribe medication, so we, you know, we talk about how much the medications may be impacting things, how to balance, sort of balance the whole person, and keeping in mind that it's really important to pay attention to physical health and to take into all of those aspects of sleep and good diet, which I know we're going to talk about all of those things, but I think those are also a part of physical health.
Right. Dr. Dewitty.
Yeah. So once again, my daughter is pretty severely impacted with seizures and with clusters. Over the course of the years, we have used, you know, rescue meds hundreds of times. And so with regards to physical health, her epilepsies, that post-ictal state, the use of emergency meds, it is profound. She loses the ability to swallow, and that has impacted her nutrition, prompting us to have to get a G-tube when she was about 12 years old because we lost the ability to get good nutrition. And it makes this physical exercise a real challenge. So PT is prioritized above all other therapies in our house, because we realize if we're not constantly on this, that we might lose her motor ability, her ability to ambulate. And that is such a critical issue with quality of life. And we have to stay on that. And sometimes it's push to stay where you are. And so what that means is that when Marie is having good days, man, we have to take advantage of these good days. We have to push to maintain. We have to regain each time after these events. And so I can't emphasize enough how critical it is to kind of take advantage of good days, and how much medication will alter her ability to do things. So you talk about this, I'm going to go back to risk just a little bit, because you have to, because you can control seizures and have a very flat child, and you are not you're not able to then utilize physical health and emotional health and all of that. So epilepsy control at any cost is not a viable option within our community, within some communities. Okay, it's not, unfortunately, it's not a possibility right now. And so you have to weigh these other things: mental health, you have to weigh physical health, how much can you maintain, and just this fight to sometimes stay where you are and to make little incremental change, gains as you go along. So anyway, that's my perspective.
Yeah, that's the phrase you use, push to maintain. That is, it really encapsulates it in a way that I hadn't thought of before. So thank you for sharing that. Dr. Joshi.
So I'll just share a little bit on the catchphrase of impact of epilepsy and its treatment on physical health. I mean, there's no secrets that the treatment of epilepsy has impact on every aspect of physical health. Many of the children, particularly children with rare epilepsies, their condition is not just seizures or just intellectual disability, but it's really a multi-system process. And so when we talk about physical health and how epilepsy impacts treatment, how epilepsy treatment impacts physical health, the medicines we use, the treatments we use definitely impact other systems also. There are interactions between the medicines that we use for treating seizures and other medicines that are used. Some children who need medicines to help with some of the mental health comorbidities or attention to help them learn, we have to be sensitive to all the medicines and other physical conditions that are being treated. And at the same time, also balance what we are using to treat epilepsy to make sure that other treatments that are equally important are not left out. So another thing I'll say over here is, as we've talked about teams and risk and the impact of treatments, is engaging other doctors as part of the sort of care team, whether it's a gastroenterologist, because medicines that they use for absolutely essential conditions that some of these children have can have an impact on the treatments that are prescribed for epilepsy. If there is a child who absolutely needs to be on a medicine to help with attention and focus, that discussion must be had with the child's either primary care doctor or mental health provider, because that can be just as important as keeping seizures under control. As we said, there are lots of seizure medicines, and I will completely endorse what Dr. DeWoody said. We can use a lot of medicines to keep seizures under control, but then the outcome of that can be you have this. And if you want a child with quality of life where they are able to participate in school and other activities and what is important to them and their families, those conditions we must take into account when we use all our treatments. So that's my perspective.
Right. Okay, well, epilepsy increases the risk of depression, anxiety disorders, and other psychiatric comorbidities. These can be exacerbated by social isolation, stigma, bullying, restrictions and limitations, and of course, the unpredictability of seizures. What do you feel are some of the most effective strategies in terms of epilepsy care and mental health care and day-to-day living to support mental health for people with rare epilepsies? Dr. Jones, do you want to start with this one?
Sure. I think one of the most important things is regular screening. Just as we kind of talked about, it's important to revisit family goals over time, and then they fluctuate. mood and anxiety and attention can all also fluctuate over time. And then if there are stressors that come up in the family life or in the world in general, that all can trigger more depressive response or an anxiety response. So I think that's why regular screenings, it's good to have, and people checking in to make sure there aren't any new concerns, or if ongoing concerns are not being addressed, or the symptoms aren't going away. You know, I also think it's also good to look at mood, just as we were speaking a moment ago, in terms of changes in the medication regimen for epilepsy or the other conditions that are involved. So just sort of making that a part of the comprehensive overview of how the kid or the individual is doing, and just checking in and making mental health sort of the same priority as seizure frequency. Sort of putting it on an equal playing field. And I think in the field of epilepsy overall, we're getting better about looking at the comorbidities. I do think, you know, when you start to think about mood and treatment and adding another medication, sometimes parents are a little hesitant to think about, you know, should we add another medication to treat the depression or the anxiety? And that's certainly a worthwhile discussion to have and to think about the implications, but also not to be too fearful of trying something. I think it's sometimes if the mood and anxiety is impacting the kid's ability to be a kid, it's really important to think about putting another treatment on board to see if that helps. If it doesn't help, we can always sort of back up and try something else again. But sometimes I think it's really good to just try and see if it improves attention, for example, or if the kid's mood is down, it pulls them up so they can engage in other activities or in school or even socially. So I think, you know, sort of reviewing, checking, evaluating how the person is doing, and then also talking about treatment options is really important in the care of anybody with epilepsy.
Okay, Dr. Joshi.
I think to build on what Dr. Jones said, which is absolutely the incidence of all these mental health disorders are fairly high in individuals, children included, with epilepsy. And I think, again, I look at it as some of the effective strategies over here is this team approach. And also looking at, you know, where is the treatment and the intervention going to have, what kind of impact is that going to have? In Michigan, for those of you who are from Michigan will know that, you know, we have, particularly in the last year with the pandemic, there has been a profound impact on school for all children. But I think many of the children with special needs, including epilepsy, have been impacted in a very different way. And schools have opened up across the state, sort of in different stages, in different waves, in different sort of formats. And one of the things that I have become a little more sensitive about in my practice, whether it's seeing a child in clinic, whether I'm seeing a child on via a virtual visit, is to really ask about this social isolation in particular, because I think that has been something that has been really big in this last year. I'm really impressed with how many schools have tried to integrate children back into the classroom in small sizes, and what a challenge that is. But that really underscores the importance of how our changing world and changing situations impact these. So, again, talking to families more, bringing that out, engaging them, and encouraging them to seek whatever help they can get, whether it's through a community, through their primary care doctor, through through their epilepsy care team or other sources, I think is really important. And being sensitive to the fact that, especially right now with everything changing in a very different way, those needs also are going to change is also really important.
Right. Dr. Dawoodi?
So I'm going, with regards to the really severely, profoundly affected, where your child is nonverbal, I'm just going to throw out a couple of different strategies. It's really hard for me to know the mental state of my daughter, who functionally is probably a toddler, if I'm really honest. And so how do we measure these things in these children? And so, what I'm going to say is journaling is so helpful. Okay. So we're all taught to keep track of seizures, and I hope everybody has a seizure diary. I think they're so important. But I would also emphasize, let's keep track of how often your child smiles, the number of good days that they have, because it is so easy with this incremental creep, especially when you try a new medicine, to just, you just lose little pieces of your child. And unless you're tracking this, it is very hard to kind of notice that. And sometimes it's almost somebody who comes in who hasn't seen your child in a little while, who comes in with a new perspective, because small changes are easy to miss. And so I just so much want to emphasize how important this keeping track of quality of life measures can really help the family make decisions on this. But also, I really want to bring in also the family in this case. And so I appreciate Dr. Jones and Joshi talking about the individual, but I want to open this conversation up just a little bit to the whole family. When my daughter first started having seizures, that first year and a half was brutal. And I remember, just silently kind of crying at a new cluster and having to give emergency meds and making the comment to my husband, I'll be so glad when I kind of get over this hump where I can deal with this, where it is not so emotionally draining. And he said to me, I hope that you never get to that point. And we were both right. Okay, we were both right, because you have to walk that line between not everything being a crisis and remaining completely empathetic to the situation. And that is a fine line that we ask caregivers to give on a daily basis. And so they need support on that and self-care on that to be able to not kind of fall off the edge in either direction. Okay, so it's like it's a line that you can fall off on both sides. And also, please be mindful of these siblings. So Taylor, my oldest daughter, said, you know what, when we came into this, you and Dad had 35 years of perspective when you started dealing with these crises, 35 years of kind of knowing that things ebb and flow and dealing with crisis management. But we came into this as children, bouncing from crisis to crisis with not much perspective. And that has a real impact that's actually been documented now. LGS and Dravet have both published really nice papers on this. So I just want to say, be mindful of the siblings and this, because depression and anxiety is so much higher in these siblings than it is in the average population. And so as we care for our families, please, let's care for our whole families. So counseling, screening of the siblings, it's so important. And let's not forget marriage counseling too, because this is tough on the parents, So just this whole idea of when we deal with this, that it's a family unit and everybody is struggling with these issues. And so self-care and maintenance is so important.
Right, really important points. Thank you. The cognitive impact of rare epilepsies can vary widely across conditions and individuals, but for many it can be a primary challenge. Common impacts include intellectual disability, ADHD, memory problems, executive function disorder, slowed processing speed, speech and language difficulties. In most cases, cognitive challenges consist of a combination of those things that are not likely to improve and others that are modifiable. Similarly, the management of cognitive difficulties often consists of a combination of compensatory strategies and efforts to directly improve modifiable cognitive functions. Can each of you share some of the more effective approaches to coping with cognitive challenges on a day-to-day basis, and then also things that might actually improve cognitive function? Dr. Jones, do you want to start on this one?
Sure. Yeah, I think, knowing that cognitive function can be impacted by lots of different things. So sleep and stress and depression and anxiety. So sometimes if you see a change in people's or individuals' performance, I mean, you can even think about it in your own life, that if you're not sleeping well, if you've had disrupted sleep, that your attention and focus is not good, and you're trying to think about what you want to say and get the right words, and they're not coming out because you're just fatigued and tired. It's not, a permanent cognitive problem. So thinking about if there are other factors in the environment that are going on that could be negatively impacting cognitive performance is important, in trying to modify those things. Getting good sleep, getting regular sleep are really important things to do. I think in terms of interventions for cognitive challenges, I think the thing that is really helpful is to be creative. There isn't one thing that works for every person, and there isn't one thing that that I can say to do in a situation, and it's gonna be the key. And so sometimes I'll tell families, okay, let's try this. Let's look at setting up these reminders and cues in the environment and see how that helps. And then when they come back, I'll say, okay, what worked and what didn't work, and how can we modify it? And instead of thinking, well, you told me to do this and it didn't work, and we kind of give up and get frustrated. I think just remembering that, we may have to sort of flip things on their head once in a while, try things differently, try things that we hadn't thought of before, and see what works and what part doesn't, and the parts that don't work, throw them out and add in some other ideas. And I think that if we kind of know that going in, that this is a work in progress, and that I'm, want to challenge your creativity. And it's really important for me to know from the family's perspective what works and doesn't work. So I often meet with the significant others and the person with the epilepsy and sort of see, how can we make it work? And they get frustrated with me because I'll say, well, why did it work? What made it work? So that if we can identify what those parts are, we can add them into the next intervention. So even back to the journaling, I think it's good to write those things down and kind of keep track of, what works, what doesn't work. And then we can kind of come together and see if we can come up with a plan and make it be more beneficial for everyone.
Okay. Dr. Gulati?
So, Marie has ring 14 syndrome. It's a large CNV, which is also what most large CNVs are highly associated with intellectual disability. So my perspective is, one, try everything. Augmented communicative devices, eye gaze, things like this, picture exchange programs. So try everything to try to get the most function out of your child, the most ability for them to have some kind of sense of identity and autonomy. This has to be consistent between your home life and your school life. So if there is no consistency in program, then this will not stick. So I would emphasize that. But also, I'm just going to bring this back to intelligence and ability in this realm is something that we all kind of want to take credit for. And this having this child and also having highly gifted children has really emphasized to me, you know, what a roll of the dice some of this stuff is, and how important it is to be gracious to people in their abilities, and realize that these are in some part gifts. Now you can do with them what you want. And the reason I say this is because nobody judges my daughter harshly, because she is so far at the end of the spectrum. They are so nice and so sweet. But I think that these children who operate on this line of being almost, you know what I mean? They can be judged so harshly. And so I just want to say, can we just show them the same grace that we show people all over the spectrum? So you walk this line between wanting to push, and have people reach their full potential. I'm all for that. But let's not be disappointed. Let's not be, if that makes sense, okay? Because they didn't ask for these disabilities, you know what I mean? And so I'm just going to do a special shout out to those people who live just kind of in that gray area in between, because I think that they are the ones that are judged most harshly. But let's be consistent in the approaches that we deal with them to give them the highest advantage to succeed, if that makes sense.
Yeah, makes perfect sense. Thank you. Dr. Joshi, just briefly.
So I'll just be very quick, because I think both Dr. Dawoodi and Dr. Jones have just highlighted some very key and important points and take-home messages for all of us. But again, I think here, when you have a child, a family, and a doctor who are all being team players in this situation, for I think one of the ways for a neurologist, an epileptologist, a primary care doctor to be an advocate for a child is to be supportive of the school program that they are in, to be cognizant of a child's abilities. And I think it's a celebration, what all our patients do. I mean, I am constantly impressed and amazed at everything the kids in my clinic do. And I think that it is a celebration. You know, how many times have I heard the story of a child with epilepsy and intellectual disabilities, a rare epilepsy? Oh, we were told you will never walk. And then, you know, does it matter? I mean, this child was 5 years old when the child started walking. Hallelujah. Somebody, you know, so I think those are moments to celebrate, because again, they're very empowering. It's very empowering. When I come home at the end of the day and I have not made somebody's seizures better, but, you know, because of the care plan that we had, this child was able to enjoy a trip to Disney, and to see the smile on the child's face, it's so clear that they are there, and that's my reward at the end of the day. So I think I absolutely endorse everything that Dr. Dawoodi and Dr. Jones said. I don't really have much to add there.
Great. Well, that's a great note to move on to our questions. We have several questions, so I'm going to try and get through as many of these as possible. And rather than have everyone respond, I'm going to have kind of first person to jump in. Let's see. Okay. Dr. Dawoodi, as you were speaking about using rescue medications hundreds of times over the years, are there any long-term effects of those?
Oh, do I wish I knew the answer to that question. Right. And so I might ask Dr. Josie or somebody who has really, I don't even know that there's been a ton of research on this, you know, evidence-based. What I will say is that I do not know my daughter off medication, and that the rescue medicines were necessary. And we had to do this. On the other hand, I will say that we try to minimize their use as much as possible. So we because that clearing your system of all of these meds is a process, and they have different half-lives, as we all know. And so we kind of alternate between drugs that have a short half-life to a long half-life to try to manage clusters so that we don't. And so I'm obviously speaking on the short term. So how do we maximize Marie's short-term health? But I have really no idea about the long-term effects, but they're necessary. They're necessary. So I wonder if Dr. Josie has anything to add to that.
I'll add a little bit. So the medicines that are typically used for rescue therapy, as Dr. DeWoody said, they are necessary in the moment. One of the things that we do keep in mind is this group of drugs called benzodiazepines, which are the most commonly used group of drugs for rescue therapy, can over time produce kind of a desensitization or a tolerance effect. So one sort of long-term effect to just be aware of is being cognizant of their effectiveness and sometimes blunting of their effectiveness. And I think that's where, being, having that discussion about which situations do you actually intervene in, how do you intervene in. I have many families in whom they have more than one rescue medication for different types of seizures, where, and we set these goals and there's an or seizure action plan that looks same for 2 children. And I think that is exactly keeping in mind some of the things that Dr. DeWoody said.
Okay, and Dr. Joshi, I'll follow up with another question. How much is known about a vagus nerve stimulator possibly causing constipation, since the vagus nerve controls propulsive peristaltic waves in the intestines?
I don't know that there has been a lot of evidence-based research on that. The common things that we know of in terms of what the vagus nerve stimulation does is more related to effects on the larynx and on the voice from its effects on the recurrent laryngeal nerve. But yes, absolutely, there is the vagus nerve is a very active player in gastrointestinal motility and many other autonomic functions, but I don't think we have a definite answer on that one.
So maybe something that benefits from further research. Okay. Dr. Jones, how do I help my daughter retain information to be successful on a test? She has an IEP and it's hard to find a good study skill to help her pass a test. So I guess specifically thinking about like retention of information, the ability to both, intake information, retain it, and then recall it for tests. I guess you probably have to look at each of those steps, right?
Yeah, I think one of the things I always do is try to find ways for multiple presentations and then using multiple modalities to do that. So hearing it, seeing it, writing it, telling it back. And where that makes this hard is that school works at a certain pace, right? So there isn't always that time in the classroom to have those multiple types of presentations. And so that might be the way that you would supplement at home or with a tutor of, knowing that in class it's presented maybe 1 or 2 ways. So at home you present it in additional ways. And sometimes finding out, what is the stronger way for your child to sort of receive and encode the information and hold on to it. So some of us are visual learners, some of us are auditory learners, some of us have to be more active learners. And I think just knowing that it's going to take multiple presentations and multiple sort of being that back to the creative piece is like, you're going to have to be creative about how you are you presenting the information, having the child rehearse the information, give you the information back. But it's definitely going to take more than, 1 or 2 presentations of the information.
Okay. Well, we do have some additional questions, but luckily we do have an open forum, so we're just going to hold on to those for the open forum. So I want to thank all of our panelists for really an excellent and nuanced discussion of such a broad topic, and really appreciate your input and your thoughts on this. So thank you, everyone. Okay, so we are going to move on to the next session. And let's see. And I'm actually, here, hold on a second here. I'm going to pass it off to Aisha Akhtar to introduce our next session. So Aisha.
Great, thank you, Russ, and good morning to everyone. Thank you for all of you who have tuned in. We had a really great night last night, so looking forward to another amazing set of panels this morning. And we are going to move into our next topic, which is on transition. And so we're going to have two speakers. Our first is, so the panel is called Planning for the Future. And our first presenter is Nadia Van. She's a disability attorney at Buell, Little and Harris. And she's also a formal special ed teacher. And so she's going to speak for about 25 minutes. And then we'll have Dr. John Milichep, who is a pediatric epileptologist from the Ann and Robert Lurie Children's Hospital in Chicago. And he will go through some of the transition toolkits and tips for you. And together they are going to share their guidance on all the different types of decisions that need to be made at this very critical time. So continue to please keep adding your questions, and we will address them when we're done. Thank you.
Good morning, everyone. My name is Nadia Van, and I am an attorney who practices in the area of special needs planning and estate planning. And thank you so much for having me here today. I'm so glad to be able to share with you. I have a screen share for our presentation, so I'm going to start that. Hopefully everyone can see it, and if you have questions, please put them into the Q&A. So I'm going to talk specifically about transition planning for adulthood, as you have children who are moving into adulthood and looking for independence, what sorts of things you might want to be looking for. So as far as choosing a path for independence, if you have a student who is underneath the eligibility categories for special education and currently receiving special education supports and services, then that transition planning is a process that is dictated by law. And sometimes it goes well, and sometimes it's pretty bumpy. So you want to make sure that transition planning begins with your child at age 14. The law varies the timeline varies from state to state, but the federal law says it should start at 16. Most places start at 14 because that's when students start in high school, and high school is a really good time to start that transition planning. So you want to make sure that during the school age, you're doing that pre-employment transition process. And so that would look like maybe rating scales, it might look like vocational education, it may look like a lot of things that students will be able to participate in during their school time. So it might be job exploration through community work-based things, or it might be independent living skills training through supported workshops in the school. They don't necessarily teach home ec anymore in schools, which is kind of sad, because I still really enjoy the tiny apron that I made when I was in voc ec class. But however, with that in mind, I also know that for lots of our students with special needs, they are doing those sorts of things in the schools just to make sure that they have more skills to be able to live independently. When you're planning this process, it really does kind of, look like making sure that students have interests that are outside of just, being in school, and also making sure that we can get the skills necessary to help them to be involved in those interests. And being involved in those interests can look a lot of different ways. So when we're looking at this process, we also have to look at whether or not students are going to graduate. In Michigan, we educate students until the age of 26. In most other jurisdictions, it is until the age of 21. So the time between graduation in 21 or 26 is what we would call those young adult programs. And those young adult programs will offer vocational support and independent living supports. Those vary, and they're usually not provided by the school district. They're usually provided by the intermediate school district, the ISD, or the Regional Education Association. And having those people in place, they usually craft those programs so students are not necessarily in a school setting, but they're in a setting, in an environment that will allow them to be able to have some particular skill sets and to be able to have some particular training for the things that they're using and the things that they're involved in every day. There are also adult employment opportunities, talent pools, community programs, supported workshops. Those are things that happen outside of the school process, outside of the ISD process. It might be the vocational rehab organization in your community or in your area. It might be a rehabilitation service. They might provide those things. We know that some of the colleges in our area provide those sorts of opportunities for people to be able to work independently and to be able to have those independent skills. And so these are things that you would want to be on the lookout for. And the best time actually to be on the lookout for these is way before a student turns 14. You want to make sure that you're being on the lookout for these types of supports and programs as soon as possible. We like to talk about transition. Well, when I was a teacher, I like to talk about transition to adulthood in the 3rd grade. And that seems like it's very early. That seems like it may even be too early to be thinking about it. But when you have a child that has a challenge, you know that this is not going to go away just because we don't talk about it. And so you want to make sure that you're starting to talk about those things as soon as possible, so that when you are going ahead and making those decisions, you have all of the tools in your toolbox in order to be able to get those things taken care of. You also want to be considering government benefits. There is Supplemental Security Income, SSI, SSDI, which is the Social Security Disability Insurance, and also Medicaid. These all have income and asset limits. And so this is always something that you're going to want to be aware of, is how much money can a person have in order to qualify for these benefits. And also the qualification process. The qualification process is definitely one of those things that is a thorn in everyone's side. It is something that is not necessarily smooth and easy for a lot of different reasons. But one of the main reasons is, of course, that these are government funded programs that are run at the state level. So when you think about things being run at the state level, each state has its own sort of hoops and hurdles that people have to go through. And then when you also think about each state having their own hoops and hurdles, each county, each local government also has their own hoops and hurdles that people may have to go through. But the things to remember about both SSI and SSDI is that their qualifications are similar but different. For SSI, that would be anyone under 65 who needs the supplemental disability, who needs the supplemental income because they're not working or they have limited work. Having limited work means that you can still work, but you can't work full time. And then there are different levels of support that can be offered based upon whether or not you live independently, whether or not you live with someone. There are different levels of support for that. SSDI in particular is for individuals who have a documented disability with the onset before age 22. And you can also work with SSDI, but again, you have to make sure that you don't reach those income limits, those asset limits, and also that you don't end up reaching the threshold for work for the month, because there's an income limit. And at last check, it was about $1,300 per month. You can't make more than that, which is really, part-time work, maybe 2 days a week if you're looking at making minimum wage. Medicaid goes along with both of those. People who qualify for these two programs will qualify for Medicaid, and that's a way for you to get government insurance to be able to take care of your needs and to be able to have treatment options. The caveat to all of that, of course, is that adulthood begins legally at age 18. So regardless of your physical or mental capacity, adulthood begins at age 18. And in order to be able to qualify as an adult, what you have to do is make sure that you are in a position to speak for your child, right? And so at age 18, regardless of whether or not you are able to make those decisions, the government says that you can't. And so we have to make sure that we plan for those things ahead of time and making sure that that happens. One of the ways that we can make sure that that happens is with a guardianship. And the guardianship 5 W's are, what is a guardianship? So a guardian is a person who's appointed by the court and given the power to make certain decisions about the care of another person. Anyone can be appointed as guardian. However, there is a legal order to the appointment of guardians. And so you want to make sure that you have that order taken care of. It usually does start with spouse, if there's a spouse involved, but after that, it does run to parents. Guardianship starts at age 18 and beyond. And then as far as why you would want a guardian, you would want a guardian if the person is incapacitated to the point that the appointment of a guardian is necessary in order to provide care. Guardianships don't have to be restrictive. They can be full or limited. Full guardianship allows for the complete management of a person's medical decisions, living decisions, financial decisions. It allows for that completely to happen. And a limited guardianship reserves some decision-making to the incapacitated person while allowing the guardian to make other decisions. A lot of times, we would prefer a limited guardianship. The court prefers a limited guardianship because in order to be able to give the person independence and give them, accountability and agency over themselves, allowing them to make certain day-to-day decisions, allowing them to be able to work, allowing them to be able to choose where they're going to live. This is the important piece for them. And then maybe the limited guardianship allows for the guardian to make contracting decisions, medical decisions, allows them to be involved in certain aspects, but it doesn't allow them to take over. Conservatorship is a way for someone to be in charge of financial affairs. The guardian can be the same as the conservator, and in order to have a guardianship and conservatorship, those are two separate processes. However, having those two separate processes doesn't mean that the same person can't be involved in both. Having a conservator is also a great way for people to be able to apply for government benefits because that way the person can be in charge of those benefits. They can be the representative payee. They can be the person that has control over all of the finances, and they can make sure that all costs and expenses are taken care of. So the process for both guardianship and conservatorship are very similar. There is a petition that you have to fill out and file with the court, and filling out and filing the petition with the court is a self-service process. A lot of lawyers will tell you that you have to have a lawyer to do this. I am here to tell you as a lawyer that you don't. It is a self-service process. There is a form that you have to fill out, and there's a form that you have to fill out. There is a medical report that has to go to the court, and then they set a hearing date. And between then and the hearing date, there is an investigation, and that's when the guardian ad litem will come and talk to the person who is the proposed ward, and will talk to the guardian to make sure that this is an arrangement that works. And then once that happens, what we will do is go to the hearing. The judge will make a ruling on the appointment. And then after the ruling on the appointment, they will go ahead and appoint the person as guardian. Once you've been appointed as guardian or conservator, there is an annual reporting requirement. The annual reporting requirement for the guardian is to make sure that the ward is doing okay, it is safe, is living in the same place, and is being taken care of. And then for the conservator, it's the reporting of the money that's been spent. And so making sure that there isn't any financial malfeasance. Not that we anticipate any financial malfeasance, but the court wants to make sure that none of those things are happening. If there is an emergency, however, if there is an emergency and your son or daughter is over 18 and you don't have a guardianship in place, you can apply for an emergency guardianship. This is a shorter process, but at the same time, it's a longer process. So we are currently looking at a 2-week time period for emergency guardianship. So if you go and apply under an emergency, what it says is, you know, we have this emergency, we need to make these decisions right now. The person who would normally make these decisions is unable to make these decisions. Can we have this guardianship? Or can we have this conservatorship? So with that in mind, what has happened is you get the authority to do that, and then the judge makes you come back to see whether or not they need to extend it. So it's a little bit longer process because you have to come back to court on multiple occasions, but at the same time, it gets you what you need in case of an emergency. You're able to do it as quickly as possible. There are, however, lots of alternatives to guardianship and conservatorship. And there are documents that you can have signed by your son or daughter, your loved one who you need to make decisions for. You can have those signed as soon as they turn 18. And those would be the patient advocate designation and the HIPAA waiver and the durable power of attorney for financial. So the patient advocate designation gives decision-making power for healthcare decisions, and it gives the ability to be able to access medical records. The durable power of attorney for financial matters gives decision-making power for financial and property decisions. So that is the same as the conservatorship, being able to have those decision-making powers and being able to get all of those things together. These can be signed, they can be drafted and signed, and they can be used as soon as a person needs them. So as soon as they're signed, they're available for use. And this is a way to not have to have court involvement. If you have these documents signed, then you don't need to get the court's approval in order to do those kinds of things. These documents are really important because it avoids the court. We spend a lot of time in court, and there's nothing wrong with spending time in court. And most often the judges are very, very, very sympathetic and understanding to the way that things are and the need for guardianship and conservatorship. And in particular, if this is a case where the person does not have capacity to sign these kinds of alternatives to guardianship and conservatorship, the courts are very understanding of this. But if you can avoid the court and avoid having court involvement, this is what we want to do. You want to make sure that you can avoid having the court become involved in all of the things that are out there. And you want to make sure that you can avoid having the court be a part of it if you can, because no one wants to have to continue to go to court every year. And if you have the opportunity to make those decisions, in particular, if you've been making those decisions now for 17 years, to have to run those by somebody else can sometimes be a jarring experience. So you want to make sure that if you can avoid them, you can get those taken care of. And then also taking a look at being able to designate those powers that your agent has. If you have a durable power of attorney for financial or a durable power of attorney for healthcare matters, then you are able to designate which powers that that person has. So if you only want to give decision-making for major healthcare decisions or major financial decisions, you can craft your documents in a way that that's what will happen and not have it be so broad and not have those powers be overreaching. So what should you be doing at all of the stages? From birth to 17.6, so that's 17 years and 6 months, you should have a will or a document that designates the care and custody of your children if you pass away. So you are able to make those decisions for children until they become 18. But if something were to happen to you, you also want to make sure that you have a custodian for your child. You want to make sure that you have a conservator for your child if necessary. If they're going to receive assets, you want to make sure that you have documents in place that will make those transitions smooth and again will avoid court. At age 17.6, so 17 years and 6 months, if you are considering guardianship and conservatorship and your child won't have the capacity to sign for some of those alternatives, you want to begin the petition process, because the petition process is, of course, filling out the form. Again, it's a self-service form. It's not difficult for you to fill that form out. However, sometimes getting a hearing date can take a really long time. And a lot of that is just dependent upon what county you're in. I practice in Ingham County. It takes somewhere between 2 and 3 months to get a court date. When I go down to practice in Wayne County, it can be anywhere from 4 to 6 months to get a court date. It just depends on where you are. So you want to make sure that you have enough time so that there's not a very large lapse between the 18th birthday and when someone's actually appointed as guardian. After 18, if you are considering an alternative for guardianship, get those documents signed. You can start having those documents drafted before age 18, but you want to make sure that you get them signed after age 18. And then if you find yourself in need of a guardianship or conservatorship, begin that petition process immediately. You can always modify your petition or withdraw your petition if it no longer becomes necessary, but you don't want to have to, start from scratch at the very beginning unless if there's an emergency and have to go through that process if you can avoid it. And with that, I will turn it over to Dr. Millichap.
Thank you, Nadia. And I just wanted to take a moment while we're transitioning to Dr. Millichap to remind everyone that this is being recorded, and all of these videos are available for everyone to watch. There's such great information coming out. And so now I'm going to turn it over to Dr. Millichap to hear the medical perspective of transition.
Hi, everyone. I'm Dr. John Millichap. Can everybody see my slides on the screen?
Yes.
Great. I'm a pediatric epileptologist, a child neurologist at Anna Robert H. Lurie Children's Hospital, Chicago. But I'm also involved with the Child Neurology Foundation and have worked in the transition realm for about 4 or 5 years now. And I've prepared these slides and given this talk before, and I think it's just a great forum to talk more. And I really enjoyed the last talk. I don't think I've seen one quite like that, and I think it's really helpful and practical. So I appreciate that. So a little bit about the Child Neurology Foundation quickly. They have several initiatives, and for all of them, they convene, collaborate, and provide a center for people to come together and find solutions to problems and to support families and people with neurological issues of all kinds. The transition project, or the transition of care program, I've been a member of the Transition Project Advisory Committee, as I said, for 4 years. And this is really the project where some resources for transition were adapted from the GOT Transitions, which is the larger pediatric sort of generic transition program resources. And these 8 common principles were released in 2016 and have been available on their website since that time. So the TPAC has, of course, child neurologists like myself, but also adult neurologists and many other stakeholders who are involved and are supported by all of our national associations like the Child Neurology Society, Child Neurology Foundation, the American Academy of Neurology, American Epilepsy Society, and others. So here's the website, and I think it's already included in the chat, so you can click on it. But so there is a website that provides all the resources I'm going to discuss, and there's a nifty interactive graphic that was created, so you can actually click it and go through all of these different principles that I'm going to illustrate in the following slides. So the 8 common principles are expectation of transition, the yearly self-management assessment, the annual discussion of medical condition and age-appropriate concerns, the evaluation of legal competency, the annual review of transition plan of care, the child neurology team responsibilities, identification of an adult provider, and finally, transfer complete. So in 2017, I was involved in a series of videos where we had families and patients involved to illustrate the case examples of the application of these common principles. So I'll have a video playing as well, and I expect that the sound will play, and I will just maybe make sure that it is ready to play, and if, I think we can make it work if it doesn't. So each of these cases will show us how to use the 8 common principles and how we develop a personalized transition plan for the patients. So the first patient has a well-controlled neurological condition, epilepsy in this case, typical development, and is expected to live independently as an adult. So Kobe is an 18-year-old with focal epilepsy. The seizure started when he was 15. His MRI and his EEG were normal and controlled with 1 seizure medication. Early on, when he was adapting to his life with epilepsy, he had a few breakthrough seizures with non-compliance.
At first, when I was diagnosed with epilepsy, I thought it was gonna kind of hold me back. Things I was like emotional about was my love for football. I had the big dream of playing in the NFL like so many other young kids.
So did you hear the video?
Yes, we did. Thank you.
Excellent. It didn't work last time, so I just checked. And so I have just a few questions dotted in here. It's much easier when I do this live. So these are more rhetorical questions to think about. But at what age would you expect a complete transition? So I think, these are all reasonable answers. They're around the age of 18 or when we become adults. But as part of our program, we selected to finally complete it at least by age 21, if possible. So the first 2 principles, so I have little boxes here. I don't expect you to read the print, it's very small, but I'll just use these images as anchors to discuss the different principles. So first, the expectations of transition. And so the graphic will point you to the different resources in the toolkit. In this case, the transition policy, which I'll describe in more detail in the next slide, and the transition checklist. And then second, the yearly self-management assessment. Obviously, this occurs every year from the beginning. And that also includes the transition checklist, but then the self-care assessment. And in this case, Kobe can fill that out himself. And then if the person was unable to fill that out, the parent or caregiver can do it on their behalf.
My doctor let me know like transitioning from a child to an adult, it would be a big step. I just like accepted it, gotta move on.
So this is a sample transition policy that a practice can use. This would be a letter that would be handed to the family. We suggest that you start doing this around 12, the age of ascent, and it can be just handing them the letter and just letting them know what the expectations are by age 18 to 21. Just that there are, two different clinics or two models of care, and that there's going to be a process, and that multiple things will happen over the subsequent years. When we see patients every 6 months or even every year in some cases, it can be good to touch on this just briefly, at least, in all the visits. And this checklist on the right here, some of it might seem very simple or redundant, things that we do anyway, but it can be helpful to keep this in the patient's file and to continue to refer to it over the subsequent years leading up to transition. Now, I mentioned the self-care assessments, and this is the sample of self-care assessment that Colby might fill out, or somebody with his ability. And the intent of this, as written here, is so that he to assess what he already knows about his health, what he already knows about using healthcare, and areas that he needs to learn about or get more help or instruction. So again, these are very sort of simple questions, and it might seem easy to do, but it's hard to remember to do this, or to know where to put this in the electronic medical record, even, so that we can refer to it. So the next 3 steps are highlighted here. The third one, we might use more personalized approach to the patient, planning different aspects of their care, things that might need more time to transition, for example, and certain specific aspects like genetic testing that I'll talk about a little bit more with the next case. And again, it has the same transition checklist and self-care assessment as the available tools. And similarly, the evaluation of legal competency, you got the long version in the last talk. And here, just as part of the self-care assessment, this will help us to start thinking about whether some of those things might be needed that were discussed last lecture. And the plan of care is reviewed annually, sort of done at the same time as the self-care assessment. And this is a joint process between the patient and family and the child neurologist.
What I learned, or he learned, is that he took ownership of his health. He's been more compliant with his medication. He knows that if he doesn't do what he needs to do, then the outcome is a seizure or possible death. So going forward, I say to parents and children that it's a step in the right direction, and you always have resources.
So I really appreciate these videos, because I think that these words are much better than the ways I could describe the importance of thinking about transition. So as a child neurologist, we don't know, or we might be concerned about how our patients will be looked after in the adult clinic, or how they'll be looked after differently in the adult clinic. We may not know the process in the clinic that our patients are considering. So there's some unknown. With my patients, and talking to my colleagues, I think that there's certain issues, like for Kobe's case, if he's going to know where he's going to be going forward, at age 18, he knows he's going to stay in a certain community, even if he's going to college there, but he knows he's going to stay in a certain community. He might want to, stop coming to the children's hospital with cartoon characters on the wall and start going to the adult hospital, even at that age, if he starts working, or if he has more, or would prefer that. And some patients might go away for college. They don't know where they're going to land, and they only have to see me annually. So they might come back and see me in the summer when they're staying with their parents. And then the other aspect is insurance, and where that would be accepted at different adult clinics that are available. But the important thing is to encourage the patient to take ownership of their medical care as early as possible. So the plan of care is pretty simple: goals, what we're doing about them, and commitment in the form of signature from both the caregiver and the clinician. The adult neurologist knows that there's a strong bond probably between the patient and their current child neurologist, and they have to be cognizant of that when they approach the family and introduce their own plan of care. And the adult neurology clinics in most cases are more specialty driven. They may not take care of as many say epilepsy specific aspects of life just because of the way that the hospital and the clinics are structured in their training and practice. So that might be an adaptation. They might be asked to sign forms they've never seen before or something like that. And these modules and the transition of care toolkit can make this a bit easier. And of course, the choosing an adult neurologist can be tricky because of the aspects of insurance and location. So here's a transfer letter sample. So this could be produced by the child neurologist's clinic. It says, dear, if we've selected adult neurologist, this person will be transitioning to your clinic and we'll have a whole transfer package. And I think an adult neurologist who receives a transfer package and a letter like this will be hopefully grateful. I think it's not always done and is really an ideal to have all of these aspects. And hopefully this toolkit makes it easier for a child neurologist to do all this work. So the medical summary, in addition to the medical record, which is often difficult to get together, all the CDs of MRIs and EEGs and so on, as well as the written records are often difficult to get together. But you can also have the medical summary, so it has all of the important things laid out for the adult neurologist and for the patient and their caregiver. So what is included in the comprehensive transfer package? It was just on the last slide, so hopefully everybody will get this right. The transfer letter, the self-care assessment, the plan of care, and the updated medical summary and emergency care plan. The answer is easy, all of the above. So all of those things are included.
My message to be the other kids transitioning would be don't be afraid, take it head on. As I continue to get older, I just this is like a part of me.
All right, thank you, Kobe. So moving on to the second case, a patient with complex conditions, intellectual developmental disabilities, and not expected to live independently. It just sort of highlights the spectrum of different patients in our clinics. So Katie was 23 years old in 2017 and lives with cerebral palsy, epilepsy, and other health issues. In infancy, she was noted to be hypotonic, in other words, a low tone or not having muscle strength and global developmental delay. At 4 years, she became more stiff or spastic and was diagnosed with cerebral palsy and a movement disorder. At her best, she walked with support and sat on her own, and she had more difficulty moving as she got older. Her first seizure started at 10, and she's had a thorough evaluation, including latest genetic testing, which has not revealed a cause.
Katie has cerebral palsy of an unknown etiology. She also has other diagnoses along with that, epilepsy. She has something called cyclic vomiting syndrome, in which she's been hospitalized for prolonged vomiting episodes.
So that's Katie's mom, and she was very happy to talk about her experience with transition. So what age would you start to discuss transition? So like with Kobe, we would, even in Katie's case, it would be about the same, that we would start talking about it at age 12, even though it might seem maybe even more scary for families to consider transitioning. She just started having seizures when she was 10. So a couple of years later, the doctor starts talking about moving to an adult practice. I think we have to, be very careful about that discussion and let them know that this is a long process. So the different aspects of the toolkit are the same for Kobe and Katie's case. We still have the expectations of transition and the yearly self-management assessment. The real difference here on number 2 is having the self-care assessment filled out by her caregiver. So the parent or caregiver expectations, I think some of the things we hear very often is they would have liked to know the process sooner, even though I said that we should start talking about it early, between 12 and 14. Honestly, we probably don't, but we are trying to get better and trying to educate ourselves and also empower families to start asking these questions. And a parent also has to assess adult providers and the practice setting, and they really know their child best, and hopefully these resources can provide an organized approach to making it a smooth transition. So 3, 4, and 5, again, these are very similar to Kobe's, except that the evaluation of legal competency will probably be, more complicated, and you can be sure that you'll need advice, like was given in the last talk, to know what the right thing to do is, but otherwise the resources are the same, just with different action items in the plan of care. The child neurologist has to recognize that this is a very slow process and can take several years. There's, often a large team at the children's hospital and multiple specialists. As Katie's mom mentioned, she has a lot of vomiting, cyclic vomiting syndrome, so it's probably followed by gastroenterologist as well, for example. And is in a wheelchair, so a doctor managing that. So there are a lot of people to move. And all these different aspects need to be gradually moved and with some coordination.
I'd say the full transition probably took a good year. We felt like we were ready. We felt very comfortable with the doctor, and she was very collaborative and very kind, and we just felt like we could talk to her. And
so obviously this is from the perspective of someone who's already made the transition, and just highlighting how long it can really take. So it's not something you have a visit on your 18th birthday and make it happen. So the adult neurologist might be concerned about taking on a complicated patient. They really have to partner with the child neurologist to learn as much as they can about the individual and how to share the plan of care. A meeting between the adult and pediatric neurologist is something that we aspire to, and it's often been very difficult. Difficult to bill for 2 providers in the same visit, but things are underway to make this a lot easier. And really with the explosion in telemedicine, this has made it a lot easier to have multiple providers together in the same visit sometimes. The first thing to do is to initiate the primary care transition. So find a family practice doctor or internal medicine doctor, somebody who will coordinate all of the medical issues. You don't want to show up at your neurologist's clinic and have blood pressure medications or some other type of care that's needed, or treatment for the cyclic vomiting, for example, and expect them to take care of it. So the idea of multiple specialists and having that primary care doctor to be sort of the hub and then the spoke is probably what the adult team specialists will be most familiar with and be expecting. And I'll just use this moment to make a plug about genetic testing. This is something that's pretty new to child neurologists. We've been doing it for over a decade, but really the last 5 years has been a huge explosion in genetic testing. And I'll just emphasize that that whole exome sequencing or other genetic testing that was performed is different from, say, other tests like an EEG or an MRI. An EEG and an MRI are time locked, or they represent the appearance of the brain at that moment in time. They were interpreted, they were reported, and that is the final report. Genetic testing, on the other hand, although the sequencing, so all of the data is the same this year and next year, the interpretation of that data is changing rapidly. So if you had a negative whole exome sequencing last year, it might be worth it for your child to ask your neurologist or geneticist, has anything changed? Is there new information about my child's genetic data? There could have been a gene discovered that's associated with the condition that she's experiencing. So it's always good to reclassify or reanalyze the data periodically.
I wish that I knew things a little sooner. I wish that I had had an organized system like the Child Neurology Foundation website.
So thank you to Katie's mom for providing her insights, and that she expects it would have been helpful for her, although she had already completed the transition by the time it was available. So wrapping up now, just want to emphasize those 8 common principles again, and our 8th and final principle of transfer complete, and that really signifies that the child neurology team has directly communicated with the adult provider to ensure that they accepted the patient and an appointment is made and kept, and they would document this in their own pediatric medical record that they've made this transition. So thank you very much, and if Aisha would like me to answer any questions, I'm happy to. Do you need me to stop sharing?
Yeah, why don't you do that? And then I do have a couple questions that have come up for each
great.
of you. So this will be great. And just a reminder for anyone who has joined. So again, this is being recorded and all of this information will be emailed to everyone, including contact information. But let's go to this question that we have. Let's see here. All right, so we're talking about transition, and we have parents who are trying to mainstream their children as much as possible. So we're talking about putting supports in. How can parents best set up a situation for success for their children, so that maybe the school is arguing for putting in some sort of education plan, but the parent doesn't necessarily think it's necessary? How can a parent navigate those waters? Maybe creating a transition plan later in life, or how do they basically be supportive of their children?
So for school-age children, I always recommend that you never go to an IEP meeting alone, not necessarily because you want to have, to intimidate the people at the table, because the people at the table are knowledgeable, but at the same time having a neutral third party there, an advocate or an attorney, or even a good friend, someone there that can take notes, someone there that can be, recording the information that's there and be able to get that information out there and back to you and in a way that makes sense later on. I think that those things are always important. And then if there is a disagreement, my thing is always never leave the room in disagreement unless you have a plan. So it's okay to disagree with the school district, but don't disagree and walk away, because if you disagree and walk away, then what happens is that plan becomes the default plan. So if you're going to disagree, then you need to go ahead and disagree. And while you're disagreeing, say, this is what I would prefer that we do. We are going to, come up with our own plan. We are going to come back to the table for mediation. You do things that move the conversation forward and don't end the conversation right there.
All right, great. And Nadia, while I have you, I think during your talk, a couple questions came up about medical guardianship. Do you want to talk about that?
Yeah, so for guardianship, that would be what we would call a limited guardianship. So it would just guardianship for making medical decisions. And what typically happens is that we will apply for full guardianship and the judge will limit the guardianship, which is fine with us if the judge limits the guardianship. But on the petitions, there's usually a space, a question that allows you to reserve certain rights to the ward. That's how it's worded on our petition. And those would be things like reserving daily living activities, reserving the power to choose where you live. And what you're typically asking is just for that power to make those medical decisions, the major medical decisions. And that is definitely a good thing to have in place, particularly when a child is transitioning from that part of their life where their parents make all of their medical decisions to that part where the law says now they have to make all of their medical decisions. So for those first years out, while that child is still learning the system, still kind of learning how the medical care works, that's a really great way to make that transition by having that limited guardianship where you're just asking for rights to make medical decisions.
Thank you. And Dr. Milichep, what advice would you give to parents about any of their children that have more severe forms of rare epilepsies in terms of transition?
Well, I think as was highlighted in the slide in Katie's case, talking to the parents about it early you might as a child neurologist or myself, I might not want to upset the family or alienate the family by bringing this topic up, but like other difficult topics that we have to discuss in the clinic, I think this is one that they deserve to hear about, and that just deliver it in a way that they understand that we are aligning with them to help their child, and that it is a long process. It could be a decade from when we first mention it, but they need to be prepared, and similarly, for patients like Kobe to discuss it early on too. You have to have the same sort of tenderness and in delivery of this important part of the plan of care. So early discussion, I think, will help. If that's one thing you do, I think that'll help a ton.
Right, never too early. And I'm really happy that you mentioned the genetic testing. That was a big theme last night. And it was put in the chat, the website, the URL by Eileen. So that's Behind the Seizure. For anyone who's under the age of 8 can get that free genetic testing done, so that we do have this more targeted therapy that's personalized for each person.
Yes, that is a great program, and there's 75 people here who've just heard it now. That if you or your doctor don't know about it, there's free genetic testing for any person who's had a seizure under the age of 8 in North America or in Chicago, or in United States.
Definitely important to take advantage. Nadia, I have a legal question for you. How does someone start the process of setting up a special needs trust for an adult child?
So this is a really good question and something that I didn't get a chance to get to during the discussion about government benefits. One of the ways to protect assets for government benefits are either first-party special needs trust, third-party special needs trust, or ABLE accounts. And there are lots of in and outs to those. However, what you can do for an adult child is you can put your money into a third-party special needs trust. So you cannot put money that your child has or is titled in their own name. So for example, if they got an inheritance, you couldn't use that to fund a special needs trust. However, if you have money that you have set aside, like an investment account or a retirement account, you can fund that into a third-party special needs trust. That money is available for the discretionary support of your child, but it does not count against the asset limit. So that's something that you can do to be able to get that funded. Although the court processes are self-service, I would definitely recommend that you contact an attorney to get a third-party special needs trust set up, or if you're going to be looking at a first-party special needs trust to make sure that it is government benefit compliant. I would make sure that you talk to somebody about that just because there are some nuances to it that can sometimes get a little tricky, and you don't want it to accidentally count against those. And then there's also, of course, ABLE accounts, which can provide an income support base on a regular monthly basis to individuals with disabilities. And those can be set up with the individual's own funds, and they won't count against the asset limit for government benefits and programs.
Thank you. I also wanted to point out, Russ had posted in the chat that many of the states that are represented here with the different affiliates do have the ability to offer an advocate to join in an IEP meeting, especially at EF Greater Chicago. If anyone is on this webinar from Chicago, we do have that ability as well. Another question has come through. Can you move inheritance into a special needs trust that has a
It depends on
so
whose inheritance.
Right.
Yeah, it depends on whose inheritance it is. If it was inherited by the person with the special need, you can move it into a trust, but it'll have to be a first-party special needs trust. And it depends upon where you are as to how that process looks. So in Michigan, the guardian would go ahead and petition the court. In Michigan, the guardian would petition the court to establish a special needs trust, a first-party special needs trust. So your child has received an inheritance, you petition the court for a protective order and to be able to establish a special needs trust for that child. And that helps to protect those funds. It helps to protect the asset limit for government benefits. And then the court, 99% of the time, the court doesn't require oversight for that. So you wouldn't have to go under conservatorship and report to the court about the special needs trust. In 1% of cases, courts are cranky and they want to see everything. So sometimes you get a cranky court that wants to see it. We also use these for settlements. So if there's been an injury and you're receiving some sort of insurance payment or settlement, we also will, because those settlements will come in the child's name, we'll also use this process in order to put that money into a special needs trust so that the child is able to access those funds and have them for discretionary spending, but keep it under the asset cap.
Great information. Really, really great. I think we are at the time to transition, pun intended, to the next panel. So I want to thank our panelists, Nadia and Dr. Millichap. Again, all of this information is going to live live on the website. So please definitely tap into all the resources that were given today. And with that, Russ, I'm going to pass it over to you for our next and final panel.
Hey, great. Thanks, Laisha. And thanks, Nadia and Dr. Millichap, for a great session. Okay, so we are going to move on to our final session, which is the Rare Epilepsies Open Forum. And on our panel today, it looks like Dr. Burkhart is not with us yet, so hopefully he will join shortly. We're going to try and see if we can track him down. But we have as our panelists, Takia Hurd, who is a pediatric epileptologist at North Shore University Health System in Chicago, and Amanda Moore, who's CEO of the Angelman Syndrome Foundation, which is located in Illinois, and the parent of a child with Angelman syndrome. So this session will provide an opportunity to ask any questions related to rare epilepsies that have not yet been addressed. And I know we had some in the queue that we'll probably get to, and some that were even asked yesterday that we didn't get a chance to get to. We also encourage you, as we're doing this, as we're answering questions, to share resources and strategies, or ask questions of other attendees using the chat feature. We really want this to be as interactive as possible. So if you noticed, like when you were joining, that someone else has a similar rare epilepsy as you're dealing with, and you want to post a question to other parents or other families who are living with that rare epilepsy, and post that in the chat room, that would be great. So I do ask that questions for our panelists be submitted through the Q&A feature, and try to limit those to just a couple of sentences if possible. In the interest of time, and because our panelists can't provide individualized medical advice through this forum, we may have to shorten or reframe some questions that are overly detailed. So let's start by having our panelists briefly introduce themselves and share a bit about their experience with rare epilepsies. So Dr. Hurd, could you start by introducing yourself?
Yes, thank you all for having me. I am Dr. Takia Hurd. I am a pediatric epileptologist currently at North Shore University Health Systems. It's a northern portion of Chicago, so we service Evanston, Lincolnshire, and Wilmette. My interactions with rare epilepsies has happened throughout my career. I did do my pediatric neurology residency and epilepsy fellowship at Boston Children's Hospital. There we had a myriad of various rare epilepsies. And there we also had a very detailed epilepsy department, which also included some of the pioneers in genetic epilepsies. So we definitely saw many different types of epilepsies. And the Children's Hospital of Boston oftentimes served as a hub for various people to come internationally to seek some of the expertise that were there at Boston Children's. So for those reasons, have been exposed to various rare epilepsies, and have continued to have that sprinkled in my practice currently.
Okay, great. Well, thank you for being here today. Oh, it looks like Dr. Burkhart has just joined us. So Amanda, can you introduce yourself?
Sure. My name is Amanda Moore. I am first and foremost a parent to Jackson Moore, who is 5 and will be a 6 in just a few days, who has Angelman syndrome. And for those of you that don't know what Angelman syndrome, it's a rare disease. It's he has the deletion portion of it, to where he has a deletion of the 15th chromosome. And so part of that, one of the hardest parts of that syndrome is the seizures. And actually, we didn't receive a diagnosis of Angelman syndrome until he had his first seizure, because individuals with Angelman syndrome may display just some developmental delays at the beginning, nonverbal. So a lot of clinicians, that we worked with at the very beginning, knowing that there was something going on, just kept telling us, let's just hold off, let's just wait. When he's 3, maybe we'll test him to see if he's on the spectrum. And we went through MRIs, EEGs, everything basically to find a diagnosis, except for genetic testing, until he had his first seizure at 2. And so, as a parent, obviously we had no experience of seizures. We had no clue what Angelman syndrome was. And so it was definitely a shock to our family, but something that, we're very appreciative of Jackson and the love and the expertise and the joy he brings us. But part of that is also, I very quickly got involved with the Angelman Syndrome Foundation when Jackson was diagnosed. And 2 years ago, I came on as the CEO. So I kind of serve in 2 purposes. One, I'm a parent, so I understand rare epilepsy. I understand the fear of watching your child have a seizure. I understand the fear of lying awake at night, terrified that your child is possibly going to have a seizure in his bed, and you just don't know. I know all those fears. But we also provide a lot of support for our families through the Angelman Syndrome Foundation, specifically around seizures, especially through our 15Q clinic network, where we have clinicians that are working and neurologists that are working daily to create standards of care and working with our individuals who have seizures. So that's a little bit of a overview of me, and super excited to be here today.
Thank you so much. And Dr. Burkhardt, can you talk just a little bit about your clinical and research interests and experience with rare epilepsies in particular?
Yep, I'm Tyson Burkhardt. I'm an associate professor at Michigan State University. And I've been seeing folks with epilepsy in my clinic since I got out of training about 9 years ago. And when you come into a place like Michigan State University, which is a little bit of a neurology desert, or had been in the past, and where there hadn't been epileptology in particular, you find that it's not just a smallish college town, it's a huge catchment area right in the middle of the state that draws people from all around. And anytime that you set up as an epilepsy expert, maybe I'll eventually attain that title, but anytime you set up to help folks who have epilepsy, whether they're rare or not, they'll flock in. And so I've seen my share of and learned from, just as well as I've done my best to help people who have rare forms of epilepsy or rare forms of neurologic disease that manifest with epilepsy as well. Yep.
Great. Well, thank you so much. And let's dive right into the questions. We'll actually start with a couple of questions, or a question that was submitted in advance of the conference. Someone mentioned that they had watched a news segment on 60 Minutes regarding CRISPR, and was wondering if there are any studies being done for possible rare epilepsy treatments or cures or anything related to CRISPR. Is anyone familiar with that?
I can speak, yeah, I can speak at least from the foundation perspective. You know, the great thing about Angelman right now is it's a very hot space for therapeutic companies and researchers, and we do have we've invested multiple efforts around CRISPR for this whole idea of unsilencing the paternal gene, with the hopes that it will produce that UBE3A that's missing from you know, with individuals with Angelman syndrome, and CRISPR is one of those methods that we're looking at. So I am not a scientist by trade, so trying to explain that method is probably not where I would benefit you all from right now. But I do know that there's a lot of exciting research, and there's a lot of exciting publications out there around CRISPR and how it's possible as a possible method for therapeutic treatment for rare diseases. I think the thing to mention too here too, what gets me excited, you know, I'm in the Angelman space, but what gets me excited about when we do have these type of methods within our spaces, if we can find a way that, or if we can prove that this is a possible therapeutic option for individuals with Angelman syndrome, think about what it can unlock for so many other rare diseases. So I know that there's a lot of publications and conversation and research happening around this method. And so that's my limited knowledge in that. Hopefully my other two amazing panelists may know a little bit more about what's happening in the space with that.
Anyone want to take a stab at that?
I can say I don't know personally of high-level trials that are going on, but there is certainly a constant buzz at conferences and more informally on neuro Twitter, which is a thing, about, I mean, especially for some of these syndromes and disorders that have single gene or single genetic area changes, right? They would seem to be, I'm thinking of Dravet and KCNQ2 and a few other things that would seem to be almost like tailor-made for a CRISPR solution.
And can you just briefly explain what CRISPR is, if there's a real CRISPR or simple explanation for that, you can, or at least explain what the acronym is.
CRISPR is a technology which allows the actual changing of the DNA sequence inside a person's cells. So whenever whenever a physician or a scientist has opined in the past, oh, well, it's genetic, like, we can try and make up for the thing that they don't have anymore, or try and tamp down the thing they have too much of, but we can't change the underlying genes. Well, we now have some technology that can allow that.
Okay, great. Dr. Hurd, did you have anything to add?
No, I didn't really have anything else to add. I mean, I feel like for the most part, they touched on the knowledge base that I was aware of.
Great, great. Okay, so another question, how many drugs do you recommend using at the same time? My son currently is on 5 plus a ketogenic diet and seems to have seizures almost every other day and many different types of seizures. He also seems to respond badly whenever we try to take one medication away. So is there a magic number? I'm sure the answer is like it depends on the individual patient, but is there a general number where you start to have like diminishing returns over a certain number of medications?
So I don't know if there's necessarily a magic number, like you say, and each time it's mainly dependent upon that person's individual situation. We oftentimes run into the complication, which sounds like is true for this child, and that when it's time to remove maybe the first medication that we feel like maybe it's been on so long that maybe is no longer helpful, that they start to have more seizures during that time. Oftentimes it's helpful to try different mechanisms of actions. And so pick different medications that have different mechanisms of actions and sort of couple them together in hopes that it will holistically take care of the seizures. And then oftentimes certain medications work well in synergy. So the combination of 2 or 3 medications together oftentimes will work well. As a whole, as epileptologists and a physician, we try to make sure that our risks are diminished and our benefits are, as widespread as possible. So that's also a little portion of trying to figure out what's the best medication group for that person.
Great. Other thoughts on how to, I guess, figure out what the right number of medications is to be on?
Well, obviously the right number of medications is the number of medications that completely extirpates the seizures and leaves them with no side effects. Oh wait, that's actually tough to figure out.
Yeah, exactly.
I agree with Dr. Hurd. It's you almost always see diminishing returns at some point, but then when you go back in many cases and try and remove something, then it turns out it was doing something after all. It's always been helpful for me to have good conversations with patients or with their parents or guardians about, let's optimize not just for seizure control per se, but for their quality of life. And that may mean that we tolerate some more seizures, especially if we're going to tolerate more of the less severe type of seizures that they suffer from. In addition, in exchange for just not being as groggy or being more with the world, or being less irritable or more tractable, etc. And so, the optimal number of medications then shifts with whatever that agreed upon goal becomes.
Right.
If I could add a parent perspective onto this, because this is something that we've dealt with several times. We had Jackson on 3 different seizure medications. And one thing that we noticed as we were doing this was that we saw a continuous decrease of appetite, to the point where there was conversation of, a G tube if we can't get him to gain weight, so forth and so on. But they were controlling the seizures really well. But then as we started talking to more of a specialist in our AS clinics, they looked at all the medications and said, like, listen, this one right here causes a decrease in appetite. So if you can bear with us for a while, it may be a little hard in the transition, but we think that we can remove this one medication, up the 2 other medications to be able to have the same effect. But in the meantime, like as we're doing that, you may see an increase in seizures. You may see some of the stuff. Let's not panic. The end goal is to get weight on him and get him eating and control his seizures. And as a parent, that's terrifying, right? You're like, you don't want to sit and watch your child have seizures. But what ended up happening is we did have a couple breakthroughs as we were switching the medication. But at the end, like once we got through that, we had a decrease in a med. So we went from 3 meds to 2, and the kids started eating like a horse. And so, but it was really challenging within that transition because we did struggle for a couple of weeks and struggle with that. Like we felt like this isn't worth it. Like, let's just put him back on. We'll just figure it out. But we soldiered through it with the support of our neurologist, of having constant conversations. Like, and so I think that there is no magic number to medications. And I think as a parent, I was incredibly shocked with how they all interact and how the side effects all interact, and that you don't have to live with what you're currently on. There could be another regimen that would improve the quality of life.
So Amanda, I want to say thank you for that. I mean, that perspective I think is super helpful, especially coming from a parent. Oftentimes I appreciate whenever parents and the care team are very patient with trying to get through that transition, because it does take a time to come for that one medication that we may decrease to come out of their system. And then it may take a little time for the other one to be optimized in their system. And along the way, there is true times in which those breakthroughs will come through. So
now, if I hadn't had that experience, Dr. Hurd, I may not be here saying like stick through it, but we made it through the other end. And it was, I mean, it ended up being the best decision. I mean, the kid gained so much weight, like no G-tube. I mean, it was a good move for us.
Okay, great. So another question about a parent who has a daughter with Aicardi syndrome, not been able to get the seizures under control, drug resistant. They had a 2/3 corpus callosotomy, and they're considering what next steps to consider, deep brain stimulation or other neurostimulations. I guess when you've tried multiple things, and what's some advice about kind of navigating that flow chart of what's next after multiple treatments have not worked?
What's especially tough in the realm of rarer syndromes is that not only will there just be less experience overall in the medical community and fewer specific trials and specific drugs, but you will sometimes also have providers who are atomized, who are all just trying to do as best as they think they can without necessarily being part of a broader community trying to tackle the same issue. So when it comes to what do you do when you've tried all the things, or most of the things that at least are quote unquote best practices, or that have some evidence behind them, and now you're left with only possible solutions that may not have as great an evidence basis behind them. That is as individualized a discussion as like how much seizures can we tolerate for a given level of adverse effects and so forth. But then it becomes, how much appetite do we have for risk for things that could go wrong, and against a often theoretical rather than practically based probability of success. I'm sure there are people out there, and I know some who would be very happy to try and put some neuropace leads into someone with an intractable epilepsy like that, and maybe that would work if you targeted the right places. Maybe it won't, but it is brain surgery at that point. So it comes down to how many seizures you have and how disabling are they, and how much appetite do you have for the risk for complications.
Great, that's great. I'm just, in the interest of time, I'm going to jump through some of these. So another question about kind of that trying to do a more personalized review of an individual's genome and looking for that kind of precision medicine that was discussed last night. Like what Dr. Dr. Dixon Salazar referenced in identifying a treatment for her daughter, where she looked very carefully at the genome, and not everyone is a neuroscientist and able to do that. So how does someone get that process started of really diving into someone's genetic testing and other elements of their epilepsy and kind of determining or finding that really super personalized precision medicine that was referenced last night?
I wasn't available last night to sort of hear all of the different things that were discussed. However, oftentimes, a good start is getting with a epileptologist and then going through the genetic testing. And then having a doctor that's interested in sort of digging further and willing to reach out to some other epileptologists or geneticists that are a little bit more specialized in identifying that special gene and seeing if there's any type of special research studies that are going along with that. So it involves a lot of, emailing and reaching out to others to sort of get to, the small group that may not be well advertised, but, through various connections, you can get to some of those geneticists and figure out if there's any specialized answers and solutions to those patients.
I would also say, there's so much power in a patient advocacy organization as well. I know not all rare diseases have a patient advocacy organization for them, but I know that at the foundation, we have geneticists that are able to actually sit down and help and review the results that understand Angelman syndrome very well. I think that one of the concerns or the complaints we've gotten from our families in the past is, you get diagnosed with a rare disease, and I'll use the example of Angelman syndrome, and then you might be working with a geneticist that has never heard of Angelman syndrome going over your report. And so that can be a real challenge, but getting in touch with, if you have a specific rare disease or a rare epilepsy, getting in touch with a foundation that supports that and asking them as well. Like, I've gotten this test, I'm really confused. I've already met with a geneticist, but still have a lot of questions. What can I do? A lot of patient advocacy organizations will have like genetics 101. So getting on and watching a YouTube video about the genetics of 101 of Angelman syndrome or of the rare disease is really important. But there's so much power in the patient advocacy organizations as well when it comes to this.
Good point.
Right. And Eileen Miller, just in the chat box, referenced some great resources on epilepsy.com on genetic testing as well. So quick question about Jevons syndrome. Does that have a genetic component?
So in general, when it comes down to Jevons syndrome, it has a mild genetic component in the sense that oftentimes those with Jevons usually will have other people in the family that may also have epilepsy. It may not be Jevons itself. It may be just a idiopathic generalized epilepsy. And generally it happens a little bit more often in girls. And I think that they've started to look into more of the genetics of various epilepsies and have found that there are some genes that go along with Jevons, but I can't say that gene is directly tied to Dravet and SCN21A.
Yeah, like the world of it's tempting and wonderful in a therapeutic sense that there are a number of syndromes and disorders that are monogenic, that have a single gene, or at least have multiple forms with their own genes that can cause a dysfunction, because CRISPR or other technologies down the line might be wonderful to help with those. But there's probably an awful lot of epileptic disorders, epileptic encephalopathies, certainly the generalized epileptic, the idiopathic generalized epilepsies, which are just insanely complicated in the genetic sense. There are probably multiple genes, some of which contribute a little more to this person, but not to this family member. And those genetic makeups are going to take forever to fully figure out.
Right. Okay, so another question about the long-term side effects of anti-seizure medications. This person was specifically asking about Keppra, but maybe talk about, that's a common concern that I hear from families and individuals, is about those long-term effects of anti-seizure medications. And maybe talk about like the differences between some of the older generation versus newer generation medications. What do we know about long-term effects?
I think anyone who comes into my clinic with taking a first generation anti-seizure medication, which would be, for the most part, would be carbamazepine, phenytoin, valproic acid, with exceptions, or phenobarbital. I will thoroughly examine why they need to be on any of those, and if possible, switch them off, because this first generation of anti-seizure medications, most of which had their effects discovered literally by accident, are unfortunately all associated with some risk of long-term and in many cases irreversible adverse effects. And as an epileptologist who takes care of adults, including in the above 65 crowd, I'm particularly concerned about bone density and postmenopausal women, folks who are older, folks who have been on multiple, what we call enzyme-inducing anti-seizure medications, like most of those first generations are, for instance. And I'll switch them if at all possible and if doable, and if the patient wants to, right? Because the patient has autonomy, and if the person who has epilepsy sees a benefit to what they're on and knows the risks and still wants to continue, then of course that is all up to them. But when we do switch, the switch is generally to a second or third generation anti-seizure medication, because the beautiful thing about them, most of them, there are certainly exceptions, is that we don't have any data that there are long-term irreversible adverse effects. And remembering that, yes, Keppra, levetiracetam was introduced to the market in the late 90s, but people had been dosed with Keppra for years before that, and in non-epilepsy trials even years before that. And I would hesitate always, of course, to say that the absence of evidence is the evidence of absence, but you don't come across those long-term problems. And people who've been on Keppra for 20 years, if I take them off for one reason or another, they say, well, it was like as if a fog had lifted and I felt back to normal again, so to speak.
Okay, great. Other thoughts on that? Or?
Yeah, so for me, with my experience in pediatric epilepsy, it's oftentimes same as Dr. Burkhart, in trying to make sure that they truly need to be on them, because some of those side effects do have long-lasting, sometimes irreversible effects. And I try to just go ahead and review the benefits and the risk. Some of the first generations tend to be better seizure drugs, but they may not be great lifestyle drugs. They may make you very sleepy. They may make you gain weight. They may make you not eat. And so, that's usually the larger discussion. And so as a team with my parents and kids, try to figure out what is it that we're actually trying to achieve. Oftentimes, some of the newer generations have less side effects, but then tend to have a little bit more breakthrough seizures, especially for some of the rare or refractory epilepsies. So oftentimes it is a balancing act. And I try to give that patient and the parent that much information so they'll know exactly where my train of thought is going to.
Okay. Challenging question. I'm challenging if I'm going to be able to pronounce this, but I have a child in daycare who has a condition called adrenoleukodystrophy. Will he develop seizures as he gets older? As of now, nothing shows on his scans. Anyone aware of the risk for seizures with someone with that condition?
This is all Dr. Hurd.
Oh, okay, so adrenoleukodystrophy is a sort of white matter disease of the brain. It will have a change on their MRI where the white matter will be different. And with time, they can develop seizures. And so that's something that we as pediatric epileptologists are always looking for or looking to rule out. And we try to make sure that the parents are aware of that piece. And sometimes it's sort of this arbitrary threshold whenever they have enough neurons to sort of become bad actors to start to develop seizures. So oftentimes they'll have the diagnosis of adrenoleukodystrophy, and then they'll get to a developmental age in which the neurons have enough connectivity and excitability to actually start to have these seizures, and then seizures may ensue.
Would you recommend doing additional MRIs in the future, even if no symptoms are present? Would there be changes?
So the MRIs are usually helpful for identifying the level of progression of disease. And for us, it's often another balancing act just because they're so young and we'll have to sedate them for them to lie still for the MRI, that we try to figure out how often is helpful, because it doesn't necessarily change what we see. You know, it sort of gives us a confirmation of what we see. So usually the family will identify he or she is getting worse, and then the MRI will prove that he or she is getting worse. And sometimes that doesn't come at the benefit of having to sedate them for the MRI just to prove that.
Okay, great. Quick question, can dilated eyes be a side effect of benzodiazepines?
Not likely.
So benzos don't necessarily cause dilation per se. I mean, oftentimes I believe it sort of goes along with the seizure itself, more so than the drug.
Recommendations for treating SCN8A epilepsy in children. Are there, I guess, first-line treatments for that particular rare epilepsy?
So usually it still sort of goes along with many of the general seizure meds to go along with that. And yeah, I wouldn't say that there's like a directed medication that we would try. I mean, you know, Dravet's have a very specific medication panel that we usually go through. But for that one, it was probably follow some of the generalized seizure medications.
Okay. Another question. My child has showed seizure activity for the past year on a monthly basis, sporadic between birth and 8. We finally had frontal sharp spikes on a sleep study, a clear MRI, and all other EEG studies. Is there more that we can do to help? So I get, you know, to kind of generalize that question, when you have done sleep studies, video EEG, MRI, and maybe not had any yield from that or any abnormalities that have provided any clarity, what, if you're not in pre-surgical evaluation, do you consider other types of neuroimaging? Do you consider other tests? Obviously genetic testing is an option as well, but I guess what other types of diagnostic options might be considered in that case?
Yeah, so having the frontal spikes could be twofold. One, it could be that the frontal spikes sort of now have introduced you to a different type of epilepsy. That's one. Two, the frontal spikes might have been there if they were untreated. Some of the seizure medications can reduce some of the spikes that you may see on EEG. And then the other question is, was there a special situation that allowed those frontal spikes to exist? Was there a reduction of medication and then the frontal spikes came out on EEG? Is it a possibility that we can increase the duration of the EEG to sort of figure out if we have a prolonged EEG, one that is 2, 3, 5 days, if we can see more epileptiform activity on EEG? Of course, you've been great in mentioning the genetic components that come along with it. There's a special autosomal dominant nocturnal frontal lobe epilepsy that this could be, but it doesn't sound like there was a comment about it, the seizures happening at night. But those are some of the things that you can further explore.
Okay. Other thoughts? Or?
Yeah, it's when you're not at the point of, you know, you haven't gotten to, you know, your second failed anti-seizure med and you're not quite thinking about resection. The electrical stuff is a clue. It's not a target quite yet, but it's a clue and a point to go further. I don't, probably where you start to do more quote unquote advanced imaging modalities is going to be slightly dependent on institution. So we generally wouldn't start doing PET scans, SPECT, etc., until we're relatively sure that we're going to explore surgical treatment. But what it comes down to is that for all too many epileptic syndromes, the treatment is still get the seizures under control with anti-seizure medications, because there are fairly few. There are more now than there were when I started training, but still very few directed treatments at the actual pathology, the actual cause for the disorder anymore.
Great. Another question that I believe was sort of brought up last night, but that goes a little further. Double cortex syndrome and band heterotopia. Again, any kind of first line treatments for that, or recommendations that are kind of unique to that syndrome?
I'm unaware of any myself.
Yeah, generally a lot of the generalized seizure meds are oftentimes, helpful for that. Sometimes the band heterotopias, if you're sort of lucky, might be an area in which a resection could be helpful, but oftentimes it's much more global to where surgical intervention is difficult to proceed with.
Okay. There was a question in the chat about severity changing over time, or like the progression of epilepsy, where maybe seizure frequency increases over time or seizure patterns may change over time. Can you talk about some of the underlying processes that contribute to these changes over time? Temporal lobe epilepsy, for example, we know that can be somewhat progressive in nature, but not necessarily sure what the mechanism is behind that. Can you just talk, broadly about some of the different things that might contribute to changes in seizure patterns over time?
Well, an obvious one would just be the development of a child. Not only are there changes in neural maturation and connectivity, and keeping in mind that our grown kids don't even fully myelinate their frontal lobes until they're 25-ish. These are, and almost certainly biochemical changes too, in terms of receptor subtypes and distributions. These are going to affect the way that whatever disorder is present interacts with the nervous system and manifests as seizures. Interestingly, we don't have a whole lot of evidence that our intervention with anti-seizure medications on their own actually can do much to delay or arrest progression of underlying disorders, except to the extent that we theoretically think that more seizures beget more seizures, which is still sort of a not a dogma sort of concept. So that's one obvious way. I think that for many of my adult patients, there are clearly patterns that are either circadian throughout the day or circahebdomerian, that's not a word, throughout the week, or seasonal, which are much easier to spot now that we have NeuroPace and we can actually, see people's seizures in a fairly reliable and robust way. But when it's not obvious at before you get to that point, the cycles of seizure severity, more seizures, more frequent seizures, and then later less and less frequent seizures, then it can seem like things are getting so much worse. And I wonder how many times I've added another medication to someone and they got better, but they were going to get better anyway, just because they came to me with an exacerbation that happened as part of a seasonal thing. And I could have put them on sugar cubes and and a month later they would have been doing better. So I think about that a lot. But that's, there's an inherent variability, unfortunately. It's not just a random dice throw.
Right. Amanda?
Add, yeah, if I could add, I mean, I think when it comes to this topic, I think the one thing from a parent perspective is, you know, when you have that community and you have those people around you that have walked the walk before you, you can see some of those patterns happen before and you can prepare yourself. Because I think that's one thing that's really terrifying for a parent who is a caretaker for someone with a rare epilepsy, is that you don't know maybe when it's going to happen. But if you can get these ideas, like, you know, for Angelman syndrome around puberty, we see some spikes in this. So if you know and you can prepare yourself ahead of time, even though as a parent sometimes it's really terrifying to read ahead and see ahead like what may be coming, but being prepared and doing your research ahead of time and saying that these are maybe seasonal spikes, or if there's really severe constipation or a lack of sleep, it could increase your chances of those seizures. If you know and just prepare yourself by connecting with those Facebook groups, the patient organizations, or, you know, families within your community that have it, I think that is a way to really battle this question as well. If you know you're heading into that time, you can have a plan with your neurologist ahead of time of like, hey, if this happens, what is the best treatment and what is the best plan for our child or our adult or whoever.
Right. So I want to just, sort of echo what Amanda was sort of talking about. Oftentimes puberty is a time in which there may be a spike or if there's hormonal changes. And sometimes kids or people will have triggers, and that trigger may be that hormonal spike. We call those catamenial seizures, if it happens to be a seizure that sort of does it. Oftentimes there may be other triggers that person or that patient may have, whether it's stressful times in their life. Then other triggers may be sort of flashing lights, one of which oftentimes some of my patients will go on these field trips as kids, and they'll go through the forest, and the flashing light is created through the sun coming through the trees. And so just have the parents to sort of be aware of that. Yes, your child can go to the field trip, but just recognize that they may be going through an area in which flashing lights exist. Some of my high school students, whenever they get old enough to go to balls and concerts and, music sort of being around, sometimes the strobe light will do it for them. And so, not to say that is a phase of life biologically, but sort of a phase of life in the sense that they're going to these now social events that tend to have some of the triggers that may be there for them to be the normal human being that they are, but it may sort of bring about an exacerbation of seizures. And then finally, sometimes there are drugs that have a tachyphylaxis, or they work well up until a certain point. And then all of a sudden they start to have diminishing returns. And sometimes the benzodiazepines will do that. And a common one is Onfi. After a couple of years, you may have to go up on the medication to make sure you get the same result. And that may be another phase, if you will, that may lead to an exacerbation of their seizures.
Oh, I think you're on mute.
Russ, you're muted. Dr. Hurt, that was an excellent point about sort of getting out into different environments, especially as teenagers and young adults.
All right, good point. So as a follow-up to the mentioning Onfi, someone asked about long-term effects of benzodiazepines, and Onfi being slightly different than a typical benzodiazepine, and asking about cognitive impairments and those sorts of things. What concerns should parents and families and patients have regarding long-term use of Onfi?
Dr. Hurt.
Sorry, I didn't want to talk over you. Go ahead.
Dr. Hurt alluded to the fact that the tachyphylaxis or a diminishing effect over time can happen. And my understanding of the literature and with my own experience is that it tends to be less of an effect with clobazam or Onfi, but not by all means ruled out. In my patient population, I also tend to deal with quite a lot of undiagnosed or undertreated anxiety and depression and other things. So I do prescribe benzodiazepines for purposes other than primary seizure prevention, although of course the meds don't get to choose what they do in the body. And with traditional benzodiazepines, we do have like this concern that long-term use may have some unrecoverable effects on cognition. It's never been, in my experience, something that would obviate its use when it's clearly indicated. And I think for the vast majority of folks in whom you would consider clobazam or Onfi as a treatment of choice, you're doing so precisely because either certain seizure types or certain epilepsies you believe it's going to work better in. It just seems to work magically for drop attacks in the patients that I have. And so you're dealing with you are treating people who have epilepsies who are already potentially looking at problems down the line from their seizures, and the risk benefit from using clobazam for years or even decades, I think, is clearly in favor of using it.
Other thoughts?
Yeah. So with me, I mean, oftentimes if we use Onfi, we will use it for the appropriate reasons. And oftentimes the patients will notice an improvement in their seizures. There may be a time in which they start to notice that their seizures are starting to come back slowly. And it would usually be at that time that I may increase their Onfi. For pediatric patients, there's times in which their metabolism increases just because of growth spurts. And sometimes that's another time in which their metabolism sort of chews up the medication faster to where I need to give them more of the medications to receive those benefits. And it doesn't necessarily result in an increase in any side effects of sedation and those types of things. Overall, it's hard to oftentimes identify if there's any cognitive effects that come along with certain seizure meds. It's because the seizure med may cause them to be sedated, but the seizures themselves may also cause them to not be able to consolidate. So oftentimes understanding the chicken and the egg, or understanding the causal effect of if the seizures is causing them to have cognitive decline, or if the seizure medication is causing them to have cognitive decline, it's hard to identify which of the two is the cause.
Patients ask me, hey doc, I can't remember, is it because of the seizures or because of the disease, or is it because of the meds? And I say, yep.
Great answer.
Yep. Amanda, can you talk just about some of the resources outside of healthcare services and kind of the Epilepsy Foundation and your organization? What are some other community resources or that you have found particularly helpful over the years in and your families have found helpful?
Sure. I think the first thing that, at least from a foundation's perspective, that we have found helpful is joining larger groups who are focusing on rare epilepsy, like REN, and like these different larger groups who are focusing on the specific rare epilepsy. What that does is it allows these large groups to collaborate to create resources that can be used across the disease spectrum. Because I think the one thing that we have trouble with our rare disease organizations is we are so small. We are small operations, but our families need resources and support quick and fast. And so when we come together and we work together, we're able to create resources that are really valuable and really important for our families. So, I mean, it could be anything from, especially with when we're working in these larger groups, we could have an issue where, someone says we would like to create something that is outside of maybe a typical seizure plan like the Epilepsy Foundation provides, maybe something more detailed on how, if something were to happen to me today, how to create a binder or a plan that would help someone transition that care easily. So creating a resource together as this large group that can be used across disease areas. So, I think that it's still a challenge, because I also think that when it comes to some of the epilepsy within specific rare diseases, there are specific treatment or standards of care that don't translate across rare diseases possibly. But when I think about specifically the rare diseases on the 15q chromosome, there are a lot of resources that you can share with all the, Dup15, Prader-Willi, Fragile X, Rett syndrome, some of those the diseases that are have a lot of the same symptoms across the board. Partnering and working together to create those resources are essential. I'd love to see more of that happen, because I think, like I said, resources are very, very, very small when it comes to these rare diseases. And Angelman is actually a pretty large, we have a large organization supporting. I can't imagine for some of these rare, ultra rare epilepsies that are out there that those resources aren't there. So the Epilepsy Foundation is amazing. It's a wonderful tool. I mean, honestly, when it comes to us, that's who we go to. And then, for us, it's building this network of clinicians that understand epilepsy and working with them and creating standards of care, creating seizure one-pagers. So the one thing that I think is great is if you can create some sort of, within your specific rare disease or within your rare epilepsy, creating a one-pager that when you go to the ER, when you go to a new neurologist, that you're taking that with them so they don't have to hunt, because a lot of them just don't have time. So this is Angelman syndrome. This is the type of epilepsy that's common. These are the type of seizures common. These are the best medications. So really working to create those standards of care around it. And I mean, it's hard to pinpoint one specific resource, but honestly, and not just because I'm here presenting with you all, the Epilepsy Foundation really is one of the best ones to go to.
Great. And as a follow-up regarding resources, any resources to help financially for a family where one parent can't work because they have to stay home with a child with a rare epilepsy? I'm sure that's a very common scenario, and resources are probably limited on that. But Amanda, can you talk more about that?
Well, I think that that's a hard one too, because when you think of epilepsy, it's not just the seizure control that you are working on, right? You're working on long-term transition care. You're working on caregiving, and you're working on your quality of life. There could be other things that deal with this and go into that, which makes it can be really challenging. And so I think that there's, when it comes to caregiving, and when it comes to, one of the things that I think that we have a real opportunity to do within the rare epilepsy world is looking at the importance of access in wherever you're at, and access to these different resources. Because the one challenge that we have as a foundation is that someone may call and say, we really need an aid, or we need support, or we need help with caretaking, we need respite, but I'm in the state of A, and they don't provide, Medicaid won't cover that, or there's not a waiver to cover that, so what do I do? Or I just think that the challenges is getting access to all of these families who are giving care to such serious diseases, and that care can translate across the United States and globally. I mean, I think access is one thing that we're really looking at the foundation right now, because when we move into possible therapeutic treatments of some of these and clinical trials, some of these medications and some of these trials are going to be invasive and can be very expensive. So how do we look at access? So I think there's a lot of different resources. Some things that you can look at you can look at the different foundations around the resources by topic. A lot of our foundations will have, like, if you're looking for beds, or you're looking for adaptive medical equipment, if you're looking for wheelchairs, if you're looking for these things, here's how to do it, and here's how to get it approved through through insurance. Because I think that's a challenge that our families have, that they'll spend years and years getting denied for things, and they have to keep fighting it. So how can we limit that burden? We also, within the REN community, worked on a transition checklist. So when you are moving into that stage, what are the things that you should be thinking about before the age of 12? From the age of 12 to 15, from 16, like it goes through like the cycles of the transition period, and these are the things you need to think about. Here's where the resources you can get, and that is available on the angelman.org site. But I'm guessing it will be more available with all the other different rare epilepsies, because it's something we created specifically for rare epilepsy that can be translated through all different rare diseases. So there's so many different, Russ, I don't think I'm giving you a great answer in a roundabout because there's so many great resources out there. I think it's all about connecting and building your community.
Yeah. Any other thoughts, Dr. Hurd or Dr. Burkhardt, about financial support for parents who have to stay home with their child?
It's very state dependent and very community dependent and often very disease dependent, which is a kind of a non-answer. But I guess what I would say is that, you know, the availability of resources to some or not to others, or for some things and not for others, they're all choices made by someone at some point in time. So if you are a person with epilepsy or a loved one of a person with epilepsy and you want to advocate, make sure that you talk to the people who are making those decisions, and make your voice heard loudly.
And I think and if I can just add to that, Tyson, the EverLife Foundation is working really, really hard on advocacy issues around the different rare diseases, which a lot of the rare epilepsies would be included in that. So if you don't know about the efforts that are happening in that area, check out EverLife Foundation because they are a wonderful resource when it comes to advocacy.
Cool, thanks.
Yeah, and I would definitely also encourage connecting with the Epilepsy Foundation's public policy team. And a couple of them will be actually speaking on a Learn and Share conference call that we have coming up next month. And I'll be sure to address this issue. But, you know, there's the infrastructure bill and the families bill, all of some pretty major initiatives on the horizon at the federal level. And a lot of that is really focused on caregivers, both for and caring for older adults, helping parents who are caring for people with disabilities. So finding out more what's in those proposed bills and how we can advocate for those would be another really important thing. So.
And if I could add to that too, really quick, Russ, I think that from a parent perspective, you feel like on a daily basis, you're fighting and you're advocating and you're exhausted. But I would say one of the things that I've learned most about having a child with a rare disease is my capability for my voice to be heard is far more than I would have ever anticipated. Before we were put in this position. So the power of your voice, even though you're exhausted and even though you're tired, there's power in that, and there's power in being collective. And so even if you think like, I don't know anything about Congress, I don't know anything about senators, legislation or whatever, you don't have to know about that to be able to share your voice and be involved in these efforts. Like I have no experience in that whatsoever, but there's so much power in your voice. And I know you're tired and I know you're exhausted, always having to be the loud person in the room shouting for your child, but it's needed. And it's just like a call to action, get involved in that. It's very important.
Right.
And then if I could just add, whenever it comes down to financial resources, one would be oftentimes going to the actual pharmaceutical company. They may not always mention it, but they oftentimes will have a special program based on need in which the pharmaceutical meds, which may be thousands of dollars a year, could be reduced to hundreds of dollars per year. And so making sure that you sort of ask for that special program, ask for that discount. And sometimes they do have samples that may be available in very, very special situations, but oftentimes making a comment about that need. It is something that I know that as a physician, I will ask my patients, the medication that you received, was it expensive? Please always let me know if it happens to be expensive, and I can try to talk to the pharmaceutical rep to see if we can get you in a program to where, dealing with your child is the biggest thing that you have to deal with, not necessarily dealing with the financial piece. If I can just, reach out to someone in the pharmaceutical realm to reduce those costs for you.
And there's great resources like the Assistance Fund, Patient Assistance Network. NORD and Global Genes often have sessions to where they'll give out stipends for families to support them. The Guaranteed Rate Foundation has a great program to help families who are struggling. And so there are different assistant programs outside of your particular rare disease that you can look into as well to help with that.
Great resources. Thanks, Amanda.
Yeah, and one more quick question here. It's maybe not going to be easy to come up with a quick answer, but how long should a child who is displaying what looks to be like seizures but has not been confirmed by EEGs, how long should that child be left untreated without med?
For me, it all depends on how frequent the seizures are and how life-threatening the seizures are. So if the seizures are happening very frequently without any, after you've had 2 unprovoked seizures, that gives you the diagnosis of epilepsy. So if we truly believe that these are seizures, and then we go ahead and treat. 1, 2, if the seizures happen to cause a lot of cardiopulmonary compromise, you sort of find that they're sort of bluing around the lips, they're bluing in the face, there's a decrease in their heart rate. There are some physical changes that come along with this seizure, despite there not being any electrographic changes. I would go ahead and treat, sooner rather than later. Just as Dr. Burkhardt said, seizures beget seizures, and we definitely don't want this to sort of grow into a bad apple that sort of causes seizures to become more uncontrolled.
Right, and certainly there are many cases where people can be diagnosed with epilepsy without and still have a normal EEG. EEG is not the only diagnostic tool. So
that very first 20-minute EEG only has a 50% chance of showing abnormalities in someone who is known to have epilepsy. Mm-hmm. So if you hear your doctor say the EEG was normal, you should interpret that as the EEG just didn't show anything this time.
Mm-hmm. Right. Okay, well, we are at the end of our conference, and thank you all so much for a really great discussion. And we covered a lot of different topics and got through all the questions. So I'm really happy we did that. And thank you so much for again, closing out what I found to be a really, really beneficial conference, and really happy that everyone could join us. So again, thanks to all of our wonderful speakers during this conference. And now I'd like to direct your attention to the chat box, where you'll find a link to our evaluation questionnaire. And when you see, there it is, please open that link now, and then take a moment to complete the evaluation as soon as you leave. We greatly appreciate your feedback. That will help us. I mean, this is the first time we've done this conference, so we really want to know what was helpful, what wasn't, what can we do to improve it, because we'd like to do this again, hopefully. So thanks again for joining us for our inaugural Upper Midwest Rare Epilepsies Conference. And please remember that we're here to help, and you can contact your local Epilepsy Foundation office or the national office at any time. We hope to hear from you. So thanks everyone, and thanks again to all of our speakers and all of our participants.
Thanks to all the epilepsy foundations out there. Y'all are doing the great work.
Yes, thanks for organizing and inviting us all. Hope it all has been helpful. Bye-bye.